Good afternoon. Good afternoon.
Good afternoon.
Thank you very much. Welcome to this public board meeting of Lancashire and South Cumbria ICB. And as always, a particular welcome to those that are watching us either online or in person. Thank you for taking the effort to do that. We have a few welcomes to do and a goodbye. So I'd first of all like to welcome Steve Spill to his first meeting as a non-executive board member as opposed to an associate non-executive. Steve is our new chair of Audit, takes over from Jim Birrell as of the end of 1st of January. I would also like to welcome Bimpe Kuti Matakenya, who is sitting there next to David Blacklock. Bimpe is an aspiring non-executive member who I'm supporting, and as such she will be observing board meetings and also the Quality and Outcomes Committee until the end of June this year. So welcome to Bimpe. She has a public health background and I think will be able to contribute a lot as well as learning during this process. And finally, welcome to Dr. Julia Finnegan, GP at Pendle View Health Centre, and Nicola is the Pendle West PCN Health Inequalities Lead. So Nicola is going to present the item on the community experience to the board today. Welcome, Nicola. I'd also like to take the opportunity to note that this is the last public board meeting for Debbie A. Tayo, who is our Director of People and leaves to commence a new role at the end of the month. We've embarrassed you on a number of occasions, Debbie, but I would like to just take this opportunity to formally thank you for the public record on behalf of myself and the board for all you've achieved in your 15 months with us. It's been a very busy 15 months and you leave us a lot better than you found us, so thank you for that. We've had apologies from regular participants Kath Wally, Vicky Gent and Sakthi, but the meeting is quorate. As always, I wish to maximise our time for discussion, so I'd ask that execs keep their introductions to a minimum, and the agenda timing should allow for some good discussion on some important areas. I'd just also like to say that we've had one question received from the public pertaining to the agenda item 10, working with people and communities, and Neil will pick that up when he takes us through his report. So without further ado, we do minutes next, sorry. Minutes of the meeting of the 27th of November. Any questions of accuracy? No, excellent, happy to receive those. And action log, there are no outstanding actions. So then, now, without further ado, I would like to move to the community experience and patient story. Andy, do you want to introduce?
I would love to. So I'm going to introduce my friend Nicola, who's a GP over in East Lancashire. Nicola and I got to know each other through the Population Health Leadership Academy, and as a result of kind of the work that we've done there, Nicola's taken some phenomenal learning and embedded it in her local community. She's going to tell that story now about how we're seeing real change happen on the ground.
Thanks, Andy. Yeah, so a little bit about me first. I'm a GP, work in Briarfield, which is Pendle, so which is kind of the furthest end of the patch from here. And Briarfield and Pendle West is quite a deprived area. We have quite a lot of ethnic minorities. A lot of people moved to our area from Pakistan in the sort of 1950s, 1960s to provide work in the factories, and now we've got quite a deprived population. I've always lived in the area and been a GP there since 2008 and a partner since 2010. I took on the Hickle role in the sort of the first tranche that went through and did the King's Fund leadership training up at Lancaster, which was a great course and taught me a lot about how to work with communities and the main thing about working with them, not doing things to them, which is kind of embedded a lot of what we've done. As part of the role, we had to look at data across the patch, and to be honest, a lot of the data across Pendle isn't good. There were several areas we could have looked at, but we were particularly taken by the smear data. We have the lowest rates for smear uptake in the whole of East Lancashire. So that's worse than Burnley, worse than Hyndburn, worse than Rosendale. We have the worst uptake for smears. A lot of that is probably related to our type of population. So Through the work we've been doing with inequalities, we employed an outreach worker, Lynn. And Lynn Lockett is just brilliant. She just weaves herself into the community. She will find a group, she will get in there, she'll bring them tea, cake, blood pressure machines, get the blood pressure checked, and through that she gets into them and she finds out what they want and what we can do to help them. We've done a lot of good work through that. So when we were talking about smears, she found a group of ladies that were sort of already been pulled together and been looking at doing champion work through oral health, and then we're looking at women's health. So we spoke to these ladies and told them the data, and they were appalled. So with the results of looking at this, we sort of said, well, what can we do? Why aren't people coming? What's stopping people coming? So the ladies told us about things that all women face. How do you fit it in? How do you get an appointment? They're worried about the test. Things that also fit with their culture. How do they explain to the family? Do they need it? Because they've only had one partner. And breaking down some of those taboos. And then through that, we had some sessions looking at the female reproductive system. There was an arts and crafts session of looking at fallopian tubes and all sorts. I wasn't at that one, but I believe it was good. But just breaking down and having chats to these ladies. Through that, we've done simple things like just ringing ladies up, saying your smear's due, do you want to book it? And booking them in, because nobody wants to hang on the phone for 10 minutes to book a smear. And then as a side of that, we decided to do a video. So through the video, we probably captured the ladies' stories, captured a lot of fears. This is a video that is rolled out to people to be shared, to share their story, to share what happened. At the moment, it's quite long for a video. It's going to be cut down onto socials, and we've got an Urdu version being dubbed as well. But yeah, we had the community bus last week, and we had to turn ladies away, unfortunately, because we had too many people coming. This has really got people talking about smears, about menopause, about HRT, all things which are taboo in the sort of Asian culture. So let's have a look at the video.
I'm 26 years old and I've been called to come in for a smear so many times, and I've just ignored it because I've been so apprehensive about it. There's a lot of stigma and it's not talked about enough in the Asian culture and community. So for me, it wasn't seen as important as it actually is. And then I went to Lynn's event and I spoke to a few organisations there, and they actually really embedded in the idea that it is so important. For me, I've just got married, I want to have kids in the future, and they kind of pressed upon that, which made me really think about what I'm actually doing and the life choices that I want to create and make for myself. And then the week after, I actually went and had it done.
Hiya, come in and have a seat. So, what are you here for today? For your smear today?
Yes.
Yeah.
I'm really quite nervous.
Okay, I'll explain what happens with the procedure in a minute.
The nurse was really lovely. She actually asked me if it was my first time, if I was nervous, if I needed a chaperone. I didn't, because she was just so gentle and caring. She was very motherly, and I think in that situation when you are on your own, that is what you need. That support where you think that it's going to be okay. And she was really quick. She talked the whole process through with me, explained why we do the test, why it's so important. And I've got to say, the experience was nothing like what I thought it was going to be, as daunting as I thought it was going to be. It was really quick, really easy. I think I was in and out in less than 10 minutes. Didn't hurt as much as I thought it was. So now I feel like I have achieved something. I'm going to be 27 in a couple of months. So I feel really good about it. At least I'll know what's going on with my body, if everything's okay, and if it's not, hopefully we can do something about that.
So we are here for this project. We just wanted to talk to the nurses, to ask some questions and get some information, like what people want to know about the smear test.
What are the reasons that they don't feel comfortable?
I think it mainly is the hesitation, shyness. We don't really much talk about this thing, how important it is for health.
What is the ideal age for doing the smear test?
Every lady's invited from the age of 24 and 6 months and up to the age of 65.
What should we do if someone feels they're embarrassed or very shy?
I think sometimes it's worth just booking in an appointment with your nurse. Sometimes that reassures you, it stops you being quite as anxious. Have a look at the room. You're behind a curtain anyway, and we have a dignity skirt. You're covered up all of the time as well. We can ask for a chaperone to come in, but we can also ask for somebody that speaks your own language, or we can use language line as well to make sure that you're happy to have that procedure. Some people don't think it's important to have it if you're not sexually active or if you're not in a relationship or you're not married. There's always a risk, even if you've never been sexually active. It's a very low risk, but there's still always a risk. It's still really important to have it, whatever age you are.
When I went for my smear, some cells they were growing, and then they referred me to hospital. Luckily, everything was fine. But if I didn't go for the test, that would have gone unidentified.
It's opening up that conversation. It's not a taboo subject, it's a part of women's health.
Go to the dentist, you have your dental check-up, get your smear done.
So my best friend, she's actually 28 and she's still not gone for it. So me actually having the courage to do it has influenced her, and now she's going to book hers. So it's not just changed my life, but it's changing other people's lives just by talking about it. I think it is really important for every woman, really, for her health and well-being to do this and to have it done. It's paramount that we have this check. We need to look after our health and put ourselves first.
Any questions or any comments?
I just wanted to thank you. I saw this in advance as well, and it's a really powerful video, and it plays to wider than just your community, but the importance of talking about women's health and women's issues more generally, but also what we can do as we tailor our approach to the specific needs of a group of people that we have. So thank you very much for that. Andy?
Yeah, if I could just make a further couple of comments, Chair. And Nicola, it's wonderful work. Congratulations. It's a brilliant video. It's making real changes in the community. Congratulations for brilliant work. We actually talked about it at the Quality Committee, didn't we, Sheena? Because one of the questions was, how do we make this not an isolated thing, but we're spreading the learning? And I wanted to offer the board and the public some assurance, really, that this is very much part of how we learn in Lancashire and South Cumbria. So actually, we've taken this learning already, and we've completely changed our approach to smear tests amongst sex workers in Blackpool. We've changed our approach to how we work with the Gypsy Roma traveller community in Lancaster and Morecambe. And what we're seeing is, again, this power of this population health inequalities approach in neighbourhoods through relationship and trust being built. What does the data tell us? How do we then share that data with the community? And how do we invite them to be part of the solution making with us? And what's really interesting is, although the data showed us in Pendle that there was an issue amongst the South Asian British community, and in Blackpool there was an issue amongst the sex worker community, and in Lancaster and Morecambe it was amongst Gypsy Roma traveller women, actually what we found is that the solution each place has been a bit different, a bit bespoke, according to what the women have taught us and told us. And as we've sat and listened with a real sense of humility and curiosity, the solutions aren't the same in each place, but the outcomes are. And so we're seeing an increase in uptake in all of these communities now as a result of taking this approach. And we're not just applying it to women's health, though that's a vital part of our strategy moving forward. It's happening in all our work across diabetes, cardiovascular disease, respiratory disease, whatever it is that the data shows us. Once we start working with communities in this way, in our neighbourhood approach, we begin to see real long-term outcomes change. And this is preventative medicine at its best. So great job, Nicola. Thank you.
Thank you.
Thank you, Andy. Any questions or observations? Tracy?
Thank you. It's just an observation, really, because it was interesting listening to Andy then talk about how we've kind of done it in different places and got the same results. But Nicola, you said that one of the key things was the data, being able to communicate that into communities so that they could really understand what was happening. But you also said we don't always have that data. So I think to me it's about the power of that data and being able to make sure that when we are collecting data that actually we're translating it so that our communities can understand it. So it's about how are we making sure that data is available, but also how do we use those people on the ground in our communities to be able to go in and communicate in a way that people understand that data as well, which I think is the key to some of that connect into those communities. So I suppose when we think about making changes, changing people's hearts and minds and changing people's behaviour, then let's not underestimate just how powerful the data is and how much we need to make sure we've got it before we even start some of this work. Thank you.
Thank you, Tracy. Any other thoughts? Yep, Asin, thank you.
Thank you, and again, a really powerful story. And I think the first observation is one conversation led to many other conversations. So the power of that peer support, and I think that can't be underestimated. And I think the conversation we had in the Quality and Outcomes Committee is how do we see this in the light of the other things that we will be looking at in our papers today. So this is not just about good engagement, it's about good performance. So if we get this right, this means there'll be early detection, early cancer screening, and perhaps it might have an impact on our gynecology waiting list and our cancer waiting list. And what we see is now increasing things like inequality gaps, but there's inequalities and there's intersectionality. So I will talk a bit more around that in our performance report. But this is replicated in other areas. I know Chris, in his organisation, they look at protected characteristics and performance. So is talking therapies the same for everyone? And it isn't. And then the interventions we need to put in place. So there's a scaling of these things across the piece and across different settings. But thank you very much.
Thank you. Yes, Aaron, thank you.
Thanks, Nicola. A really powerful story, and I've got a little bit to say in my Chief Exec's report, so I'm on week 10 or 11 now, but already I've been out to East Lancashire, West Lancashire, Blackburn with Darwin. What's powerful to me is this isn't a corporate initiative. It doesn't sit at a board under a performance report in the way that Asim might have articulated. And I think there's a real challenge for us to think about how do you give away autonomy, control, budget, the access to data and the interpretation, and let communities work on outcomes that, in the approach that you're taking, it's different everywhere. And I think that can make boards uncomfortable sometimes because it's not consistent and it's hard to report and get a scalable conversation. So one of the offers I've got is to come out and talk again about place and neighbourhood and what are the key factors we need to get in place that allow stories like this to be the norm, not it's an example of a story that the board needs to hear because it's unusual and we need to celebrate it. We won't stop doing that, by the way, but we need to make that a business as usual item. So it really commend the work. The scalability is important, but I think the point that Andy and yourself have made about specific and different is something that we might have to square off when we think about the body corporate's view of what good looks like.
Yeah, I think the other thing is this takes time. Lynn has taken a long time to build up these ladies' confidence, to get them to be able to come on film and discuss these. This is Asian culture. It's not something that is easily discussed, and that has been lots of cake, lots of tea, events. They wanted money for spices. It's not a fortune for us to pay some spices for them to do a community event and things, but it's just winning that trust and winning it's the key people, as you say. It's the champions that we've now got, now going out and sort of and passing that on, because you listen more to your friends than you do to your doctor. So that's, I mean, more recently they've been on the radio. We've had them talking on Pendle Radio and selling the services of the smear bus and things. So they're kind of running with it, these ladies. They're enjoying it. It's what we're going to put them on next. So.
Great, thank you very much indeed. Okay, so just before I go to my chair's report, I omitted to do the declarations of interest. We haven't received any for today's meeting, but just for the record, can I confirm that there aren't any? No, great, thank you. So, my report, I'll take it as read, very happy to answer any questions as ever, but just a few words at the head of the board. It is very busy indeed at the moment, both across providers and within the ICB. There are huge efforts underway at the moment on both performance, especially waiting list reductions, and finance. These will be discussed in the performance report and the finance report respectively. There's also significant work underway to develop our clinical strategy and the 5-year commissioning plan. These will be brought to a future board, but Neil's insight report touches on the public and stakeholder engagement that is underway to inform this critical work. And thirdly, a great deal of work is underway to develop our operating model for the future, incorporating the significant reductions that we've talked about in previous boards in our running costs. And alongside this, of course, we've had the voluntary redundancy programme, which has been underway for the last couple of months. And I just want to recognise that our staff have had to wait far longer than anyone would have wanted for the clarity around this, the voluntary redundancy scheme, and that this has caused enormous uncertainty and stress. I'd like to thank Debbie and all her team, but also all the executives and the managers throughout the organisation for the professionalism, efficiency, but most of all compassion with which they've led both through the period of uncertainty and through this VR process itself. A number of our colleagues are leaving the ICB, across the ICB, are leaving over the next couple of months, and I know the board would want to join me to wish them all the very best in their future endeavours. That's all I really wanted to say. I'm very happy to take any questions on the formal report as well. No, in which case I'm going to hand over to Aaron.
Thank you, Chair. So, colleagues have got the paper, so I won't run through that in detail and assume that's taken as read. But just a few reflections from me, just having completed my second month now in the role of Chief Executive. I'm going to start off with a thank you. Firstly to Debbie. Thank you very much, Debbie, for your efforts over the last 15 months, but specifically and personally to me over the last couple of months. I found your advice, your support and your kindness in working through some very difficult things exemplary, so I wish you well in your future role. But a thank you to a number of colleagues in the system and the system generally. So, as the Chair's just outlined, we are going through some pretty unprecedented challenges as an organisation, trying to make sure that we deliver what our communities expect of us rightly in terms of the service standards and access standards, trying to make sure we balance against the really challenging budget, setting our plans that are really ambitious for this next 3 years and trying to incorporate as many examples of the type that Nicola's just articulated to show our commitment to place, neighbourhood and population health development, at the same time as almost 200 colleagues going through a VR process currently, as you outlined, Chair, and with more change to come. And what I've seen is a resolute focus on looking after each other, focusing on the actions that we need to take and progressing the agendas as best we can. Now, that's not perfect and people will make mistakes, and the human condition means that there's frustration and fear about the future. So we've tried to do what we can with a really, really comprehensive offer from our organisational development team about leaving well and staying well, and recognising that there are some colleagues that are leaving the organisation and also some colleagues that are going to be staying for the future. And that's hard for teams who might have colleagues in both of those spaces. So we're just doing a lot of focused work with our teams around that particular set of circumstances. And secondly, I wanted to recognise the pressure that our providers and the system's been under over the last probably 6 or 8 weeks in what can traditionally be called winter pressures, but can feature at most times of the year at the moment, particularly in urgent care, where we've seen long ambulance delays, issues with patient care on corridors and issues around performance in urgent care. However, what I have seen is real tenacity, real innovation and a real coming together in the system over the Christmas and winter period to try and keep our services as safe as we can, to deliver services that we know are not where we would want to be through winter, but would satisfy the requirements of those using the service and see ourselves safely through the winter period. Particularly the work of the provider collaborative and our mental health providers, the work of general practice and primary care, coordinated with our strategic command centre with Simon Raffaelli and Wendy Lewis and Craig's team. It's been a real team sport, and it's been a pleasure to be part of. And see, I've seen this from the other side, haven't I, as a chief exec and a provider for a long time, but it was interesting to see the system come together and how that's managed. So a thank you to colleagues and our providers in the system, and a thank you to our colleagues in the ICB chair for the work they've done. As part of kind of this next phase, we've been testing a story, a narrative about our future with colleagues, and we've been taking that out with stakeholders and team briefs over the last 3 or 4 weeks. That's landing really well and starts to give us a bit of clarity on what it means to be a strategic commissioner in the future. And Chair, when we bring our medium-term plan and our strategic narrative for our commissioning intentions, we'll start to flesh out a bit more for the public about what it means to be a strategic commissioner, what the role of the ICB will be in the future, what our community should be expecting from us through this next phase. But I've been pleased with the contribution from partners and the receipt we've had from our own staff on how that story's starting to build. I look forward to sharing that publicly with the board as it develops, Chair. The real focus for our teams at the moment is a combination of what I just said around landing the year safely and building our plan for next year. But we've also had a period where we're looking at recruiting to a new executive team. So colleagues will know we've gone out to advert. We have our events set up this week and next week for stakeholders and interview panels. And I'm delighted with the calibre of candidates that have come forward and to apply for those roles. It's always nervous, isn't it, in a period of change and new organisational structures forming as to how people might respond. But I'm delighted with the calibre we have, and I'm looking forward to working with colleagues next week on hopefully recruiting colleagues to the executive team. We've also been focusing on really understanding what our places and neighbourhoods are saying around how it feels to be working with the ICB at the moment. And I've been out, I was saying to Nicola and Tracy earlier, to East Lancashire, to West Lancashire, Blackburn with Darwen, to go and visit and see firsthand how things like place and neighbourhoods work effectively. And what I heard was real innovation and a real appetite from partners to work collectively with communities to improve. I also heard it's really hard to do business with us as an ICB. The way that we contract, the way that we allocate money, the way that we give permissions. This is all something that we need to consider when we talk about that strategic commissioning framework and our strategy, Chair. And you and I have talked about this a lot. We need to be much more permissive, much more trusting, giving much more autonomy to those communities and our colleagues who work in those communities to take the actions that are needed locally. And there's a commitment from me and from us to develop that into our new way of working. And then finally, Chair, there's a couple of items under the Executive Committee for approvals. So just to note, there's a couple of areas that the Exec Committee have progressed under the mandate that we have from the board, and they're contained in the paper, Chair. So just a few minutes update from me.
Thank you. Thank you, Aaron. Any questions for Aaron? Yes, David.
Thanks, Aaron. I suppose, as you're talking about all of the changes that are taking place, the reorganisation, the workforce pressures, I'd be interested to just really understand how the board intends to, and the organisation intends to understand the impact on patients and safety, really. You know, losing hundreds of staff will have an impact, and I guess we've got to keep our eye to that and really understand what it is. So do we have any thoughts around how that's happening, and can you give some assurance, please?
Yeah, of course, David. It's a great question. So when we're making these changes, we have two questions that we have to satisfy. We have to operate within our budget that's been allocated, and there's a challenge now to present something that shows how we do that. But we have to remain organisationally effective, which means delivering on our mandate. Part of that is the quality and safety of services and delivering on statutory mandated access targets. Now, when ASIM puts the performance report forward, you will see that we're not doing that everywhere currently. So there is a challenge for us to demonstrate how we maintain or improve that through this period of change. What we have, though, is good information sources. We have good connections and oversight with our providers and the market, I would call it. And we have a skilled set of business analytics, kind of quality and safety infrastructure, and a quality and safety committee, quality oversight committee that operates effectively. So what we'll be doing through the period of change is having a heightened sense of a risk appetite to know when things aren't working effectively. And the other thing we talked about just this morning is how do we test the effectiveness of the changes that we're making, not just from a quality and safety, but is it delivering what we thought it would? So once we've finished the piece of work, we will be working with the board at 3, 6 and 12-month iterations just to check that the operating models are delivering what we expect. Largely what we're looking at here is aligning to the strategic commissioning framework that's been announced nationally. So we will be prioritising things like data and business analytics, about contracting and commissioning in a different way, and building our capability and capacity for monitoring contract oversight for quality and safety. So we'll be strengthening in those areas. Some of the areas we won't be delivering in the future are around performance, around our people services, and they'll be delivered elsewhere in the system at region. So it's not simply we're getting smaller and having to do everything, so there's a risk. There still is a risk, by the way, that we need to address. But there are parts of what we do currently that we won't be doing in the future, which helps kind of satisfy some of that. But it will be visible to the board over this period that we keep that escalated view of quality and safety and the effectiveness of the governance changes.
Thank you for the question, David. Denise.
I suppose just to say thank you to Emma and to Aaron for positive comments about your visits to place in Blackburn with Darwen and other parts of East Lancashire. And I think, I'm sure you'll find it elsewhere, that will show the really positive joint work that goes on the ground across all partners in the system, but the VCFSE as well. And I think that gives us a bit of encouragement that we've all got capacity challenges, and obviously the ICB is in the middle of a lot of change, but if we can get the governance right to work at neighbourhood level and in place, there's that willingness and commitment to do the best for all our communities. And the example we had earlier, we're learning from that as well, and it is taking that learning in to improve healthy life outcomes for people. So thank you for your positive comments, and there is a commitment to continuing to work together.
Thank you very much indeed, Denise. Any other questions or comments for Aaron? No? Oh yes, sorry, Debbie.
Thanks, Chair. I just wanted to ask for a little bit of additional information around 8.4, if that's okay. So there's mentioned that there's an expansion of the enhanced prior approval scheme for procedures of limited clinical value. Lots of sort of abbreviation. So I'm just wondering, obviously given the decision just being mentioned to us, what the benefits are of the expansion of that approach from Central Lancs across the whole of the footprint. And I'm just interested in sort of the clinical engagement around the decision making and how we sort of engage with the public. So I'm just reflecting back to the input we had at the start and the importance of that conversation with people so that they understand if things are changing and decisions are being taken, sort of why and on what basis.
Thanks, Debbie. If possible, I'll bring in Craig and Andy just to give a reflection there on the process we've followed in clinical engagement. Craig.
Sorry, when we're obviously considering our clinical decision making, we need to look at that impact. So a lot of work we've done has been considering impact of decisions, which also looks at how we triangulate our... Sorry. All right. So, can you hear me now? Sorry. It's hard when they ask the question, but apologise. Yeah, I appreciate that. Thank you. So, sorry, the clinical engagement, and Andy can probably come in on some of the specifics. When we're looking at it through our governance arrangements, we look at it from an impact perspective as well. So we'd look at the advice our clinicians are giving us, the impact that those decisions will be having and whether they be adversely impacting particular communities. So there's obviously we're not seeing the detail here, and I can take that offline if that's helpful, Debbie, to go through the specifics because they're not in front of me now. So I'd want to be able to, if you want further assurance, I'm happy to do that outside of the room, but it's just to give you reassurance that that is considered as a part of the process, and it features in the decision making as well as the preparation for the decision making.
Andy?
Yes, and just as part of our governance processes, anytime we're making changes, we have a group of clinicians that we bring together as a part of a consultation process from various different backgrounds who we invite round the table to consider the clinical implications of any changes that we're making, and that then feeds through into the quality and safety group as well.
Yeah, Aaron.
Yeah, thank you. So again, it helps having two hats, having worked in providers. So often when we talk about commissioning decisions, they're driven by clinical colleagues feeding back to us to say, actually, the evidence here isn't great and it's occupying a lot of resource, a lot of time. And I think Central had an approach to having that feedback and then lead into an action that allows us to either decommission or reduce that kind of activity in a way that, if we spread it out, is helping other organisations in the patch do something that's a bit evidence-based. It's got a process and a criteria around it. It's commissioning supported. So this is about listening to clinical colleagues as well and creating a response that allows them to, I guess, to deliver the services that add the most value. Because at the moment, when we talk in the performance report around things like elective recovery, cancer and diagnostics, often a lot of our clinical teams are occupied in some of those areas like outpatient follow-up activities or some of these procedures that, because they're still commissioned in this way and they have a waiting list, the pipes are just open to continue to feed it. So this is helping us listen to our clinical colleagues. And I think to Craig's offer, just giving a view, a short briefing on what kind of impact have we seen in Central and what it is that we're trying to do across the patch we can provide offline.
Yeah, thank you. Is this on the same subject? Yeah, thanks. Julie.
Chair, I think it's really important that we recognise clinical effectiveness, but how we communicate that with our communities is very challenging. So I'll just draw an example. So the injections into people's backs is a very hot topic currently for the ICB. But if you're a patient who's had an injection that has given you quality of life back and got you back on your feet, talking to them about that there's no evidence for it becomes a very, very difficult situation, and how you offer that person an alternative when their quality of life has become quite dependent on something. So I foresee some very challenging conversations, and it's how we make sure, yes, clinically we're following the evidence, but how do we engage with our communities on that?
This is actually quite an important conversation because these are absolutely decisions that we are going to have to engage with and then communicate, but also on the basis of the patient experience as well. So it's a really good question. Thank you. Okay, I think we can move on, and I think we're moving on to the quarterly report of the Board Assurance Framework. Deb.
Thank you, Chair. I will take the report and the detail within the report as read. It presents the Board Assurance Framework in full. It summarises the progress that's been made over Q3 to the management of the 8 principal risks that have been identified as having the potential to impact on the achievement of our strategic objectives, and just reflecting on the conversations so far, and I think, you know, some of what Aaron's articulated and some of the further probing, I think we can already see that those 8 principal risks absolutely align to, you know, the discussions that are coming out through the board and through its agenda. So since the last presentation in September, the BAF has been further strengthened, so it now incorporates the board's risk appetite aligned to each of those risks. There's been a full review of assurances, gaps and controls and mitigations, and there's been quarterly assurance mapping against the 4 lines of defence, which you'll see within each of those principal risks. There's been regular oversight and review that's been maintained throughout the period through the Executive Committee and through the relevant ICB assuring committees. Mersey Internal Audit have completed their Phase 1 review of the assurance framework, and we got really positive findings. There were 2 or 3 areas for improvement, some of which I've touched on and we've already addressed. So we're ensuring that we're taking those forward. Section 3 of the report summarises each risk, and there's a succinct narrative that provides the board with the focus on that management and activity of each of those risks over the period. And there are also 4 recommendations within Section 3, 3 to extend the target date for the date for the target risk score, and 1 where we are reducing the Q3 current risk score. So that is now on target. That's for transition to ICB. It also includes a summary of the operational risks that are scored as high, and therefore under our policy are alerted to the board, and the next steps. And I think again, you know, referring to what Aaron has described, so alongside the work around the ICB's medium-term plan, 5-year strategic commissioning plan, transition to the ICB operating model, we need to do that full refresh of the BAF, our strategic objectives and risk appetite, and that will be planned in over Q1 of 26-27.
Thank you. Thank you. Thank you very much, Deb. Okay, questions for Deb. questions on the BAF, on the risk register, before I move to approve the proposed changes? No? Yes, Sheena, thank you.
Don't have any questions, but I think it's useful, particularly for members of the public and other people seeing our meeting, to actually behind this is a whole load of work. And I think, you know, when I was reading this in preparation, I kind of sort of, it's a really, really good report, so thank you, Deborah. But it's that whole bit about people just getting the understanding about how the work of the sort of assurance is done mainly in the subcommittees of the board. So I just really wanted to kind of pull through when we get on to things like the operational risks. I'm on page 55, that are things that are coming through in our AAA reports. Yeah. So it's really just about sort of demonstrating how it works in practice, just so that people get that assurance around this isn't just something that comes in this way to the board. It's, you know, the kind of the heavy lifting is done within the subcommittees of the board. That said, we can always improve what we do. So one of the things that, you know, in the Quality and Outcomes Committee that I chair is that we're continually thinking about, are we getting the assurances we need? How are we seeing that? Particularly things like the impact. So that change in, you know, what have we actually said we're going to do to reduce risk? Is it having an impact? What do we further need to do? So I just want to just kind of bring that to sort of not people around the board's attention, because they all know that, but I think it just gives a bit more sort of colour into for people observing the board or you know, sort of reading our papers. Thank you.
Thank you. I think that's very helpful. Deb?
Sorry, yes, thank you, Sheena. And just to add to that, from that external perspective as well, and what came out from the MIAA assurance review, was that, you know, the board assurance framework is very much visible throughout the organisation, you know, and it has oversight. So it's not something that just comes to the board at a point in time. Thank you.
And I think that's important. And we also, one of the principal risks is the transition, which of course is something that we are going through at the moment and living and breathing that risk. But this is essentially a statement of where we're trying to, what are our principal objectives and what are the principal risks to achieving those objectives, and what are we doing to mitigate those risks. And as such, it's a really important document. Tracy.
Thank you, Chair. Yeah, it follows on a little bit from Sheena's comment, really, but I just wanted to sort of highlight the fact that this BAF, and again, Deborah, you know, a really, really good paper, but some of the mitigating actions are things that are very clearly external to the ICB and really welcome in my view, because it really demonstrates, and again, I think, you know, I'm very mindful that this meeting's in public. It can be a very dry thing, can't it, a board assurance framework? It can seem like it's a very internal document, a very internal process, but actually the sense of this and a thread that runs throughout it is this is about us going out there and listening and understanding how do we mitigate some of these risks, not just internally, but by listening to people outside of the organisation. So, yeah, you know, I really got a sense of that, Deborah, so thank you for that.
Good. Denise.
Thank you. I think it would probably be wrong of me not to comment that all age continuing care and affordability of it is also a significant risk for local authority partners, and whilst we need to keep people at the heart of what we're doing as a partnership, we need to make sure we're not transferring risk between ourselves and we manage this collectively, and it's a significant risk for all the organisations involved in it. We need to remember the individual at the heart of this, but make sure that we're supporting and not having a detrimental effect on each other when we look at this.
Yeah, absolutely. And I know we've made a huge amount of progress on that over the last 12 months. Okay, I'm going to move to, so there are a number of changes that have been proposed. I think it was 3.4, I had them a minute. Yes, here we go. So proposed recommendations outlined in the BAF risk update. So the first one is around strategic commissioning to extend the target risk score. So this is where we are aiming to get the risk level down to the 30th of June to align with the timescales for the development of the medium-term plan. Happy to do that? Good. The second one is the second risk, transition to the model ICB blueprint, which is to support the reduction in current risk score from 20 to 16, reflecting the huge amount of work that has been undertaken through the executive, and approve the target risk score date to be brought forward from the 31st of March 27 to the 30th of October 26. Are we happy to do that? Thank you. The third one is under BAF 3, sustainable workforce, to support the extension of the target risk score from 31st of March 26 to the 30th of June to allow again to transition timescales. And fourthly, the BAF 8, resilient and responsive healthcare services, support the extension of the target risk score date to the 30th of June to align with the timescales for the development of the 3-year clinical strategy. All of these are related to the work that's underway at the moment. Thank you. Good, okay, that's excellent. So we will now move on to the People and Culture Committee Escalation and Assurance Report. Jane.
Thank you, Chair. We don't have a formal written report from the committee because we only met last week, so I'll give a bit of a verbal update. The committee approved 3 plans. The first one was the multi-year workforce plan, and that in a sense is a work in progress because the updated plan is actually going to be brought to the board in February. Then the two plans are particularly relevant to everything we've been talking about the period of change we're in. One is the organisational development strategy and plan, and the other one is the wellbeing and staff experience improvement plan. With all these plans, it is the role of the committee to approve, to keep oversight, to monitor and evaluate. I think, though, that it is worth just keeping the board alerted to the fact that the metrics around wellbeing and staff absence and experience are not as we would want them to be, and that's not news, is it? That's been reported to the board before, and there does need to be improvement, and we just need the board to just remain alert to that, and hopefully, as we go through this period of transition, as also we implement the mitigations in the plan, that will start to improve. The other area that we received information on was actually a report from our providers. It had been raised, I think, previously through the Finance Committee around concerns around sickness, absence and productivity across the wider system. And so we had an update from our provider collaborative representative on the committee about all the actions that are underway to try and address this problem. I did want to just mention one thing that was really quite striking in terms of, particularly to me as well as committee members, was the high correlation between sickness, absence of the workforce and population and health in a geographical area. You can draw it by geographical boundaries almost, and of course our staff are drawn from our population. So one of the most significant things we can do to improve absence and health of our staff is to actually improve, health and well-being of our population. So it might be stating the obvious, but actually it seemed quite important to me that we actually drew that out. Another area that we received information on was an initiative called Get Lancashire Working. There's a similar initiative going to be in place for Cumbria. And this is about reducing economic activity. It's a big partnership project involving different agencies. From government, it's Department of Work and Pensions as well as Department of Health. And it's all about that kind of whole health and wealth agenda and about, improving people who are economically inactive and trying to get them back into work and contributing to their own well-being and wealth as well as that of the wider economy, which is quite interesting. And of course, as you would expect, we're keeping an eye on the workforce implications of the transition and the voluntary redundancy scheme. Happy to take questions on any of that, Emma.
Thank you. We've talked about the role of this committee in the long run. It's certainly very busy at the moment. Any questions for Jane? No, thank you. But it's good to know that you are dealing with these things that have come down from board. These are really important issues. Okay, the next item is Working with People and Communities Insight Report.
Thanks, Chair. So as you said at the beginning of the meeting, we did receive a question in relation to this item. I won't read the question in full, but in summary, it related to the assurance that this board has in relation to the work that we do around engagement involvement, our approaches, how we work with patient public representatives, and how the work that we do is in line with the national policy around working in partnership with people and communities. So in response, I've agreed to meet with the individual, but I'm actually going to use a little bit of how I frame the beginning of this report to maybe answer some of those questions. Hopefully that might be a little bit useful. So in particular, some of that is looking at the way in which we undertake, or the way in which we listen, involve and engage people in everything that we do. So how we hear local voices, how we make sure insights are captured, how we take that work and empower some of our teams to work with some of our communities. So you've already heard a couple of examples on the board already around some of the community story and some of the previous boards as well, where some of our teams are absolutely being empowered to make sure that it's everybody within this organisation's job to make sure we're listening and working with communities. That is a big culture shift. That is a bit of work, a journey that we've been on over the last 3 years, in how we make sure we support some of our colleagues to think and work in that way. And I think through the report you're seeing some signs and examples of where that's starting to happen as well. And where it's important for us to do more of that. So just going to cover about 4 areas, if that's okay. So one, some of the examples of how we're supporting our teams and our place teams to embed that engagement involvement, how we're listening to people, how do we use some of those examples of how we use data and then engage. So you can see in the report there are some examples around some of the work we're doing around cancer, how we're making sure that we embedding people's views, but also working with some of our organisations like Spring North to really roll out an engagement approach around how we do that. You'll also see in some of the board papers as well, we've got cover reports which show some of those examples. So some of those individual pieces of work, making sure that we are engaging with people on those specific pieces of work. And you can see, for example, the work we've done on the clinical strategy and the commissioning plan, absolutely working with people from the start on those. The second area are examples of service change. So we know that we have a statutory duty to involve people in the way that we undertake service change, and there are again some examples in the paper that describe how we're using that duty, how we're listening to people, and there is some really frank and honest feedback that we've received that we're absolutely taking on board in the way that we deliver and take forward service change. So that's included there. There's something about how do we work with partners, work with voluntary sector organisations, how we work with Healthwatch. Again, that work that we're talking about rolling out with Spring North, but also there's a really excellent report from local Healthwatch, in particular Healthwatch Blackpool in the report, really useful insights and the partnership meetings we have with them to make sure that we actually do use that insight and bring it into some of the work that we're doing is really important, but absolutely commend the work of local Healthwatch in some of that space. The final example is where we're convening or working with partners and trying to influence public voice across the system. So 2 examples in the paper that you can see. One around how we're working with the trusts around maternity, neonatal teams and Healthwatch as well, around our maternity and neonatal voice partnerships. We're looking at that to make sure that we strengthen it, to make sure that the way that we engage with women on that journey is the best that it can be. How do we do that in a really good way? We've got some good work to build on, but we've been doing some work working with those teams to look at how do we improve that. And again, recognition that a lot of this is our different teams in the ICB really thinking differently about how they engage with people. So the cancer and maternity teams are ones to point out there in this report. The other example is how do we work with patient participation groups. This has been something our group of citizens advisors has been really vocal about, thinking that this is really important. And they're right, because if we can work and support our GPs to better engage with patient participation groups, it's a route to be able to improve better engagement with some of our neighbourhoods as well. Because it's so absolutely the work that we've done there is to get large number of responses from our practices about what's working well, and we're trying to roll out what's that good practice. How can we work with some of those areas that said we don't have something at the minute, but actually can we put that extra support to look at how do we set some of those things up as well. So and that's something that, as I say, our patient advisor group is really passionate that we do really well. And also, how do we work with some of our MPs? We know they're important stakeholders in the way that they work with their constituents and how they advocate for their local residents as well. well. So there's a bit in there about how do we deal with that. Just some final brief reports. In section 5, you can see that links to the community story and some of the work around cancer. We've seen a really positive initial response to the launch of that work around early signs, detection signs of cancer, and we're really pleased with that. But again, that approach to campaigning is not just sharing some materials, it's absolutely working with the voluntary sector in the way that that's rolled out. So I know that that's a really important part of our work with the voluntary sector partnership. And finally, section 7 includes some of the more detail. So we know that there are some additional links in there to some of the reports from both our organisation and others as well. And just a reassurance that we're absolutely making sure we work with our programme teams to listen to some of that feedback and make sure that we are building that into the work that we do going forward. So that's particularly on some of those service change examples, and we know some of that's really honest. So happy to take any questions, but I hope that just frames some of the work we're trying to provide some assurance to the group, to this board, about the work that we do around engagement involvement.
Thank you, Neil. I find this a really helpful report, actually. It started to give me some real assurance about how insight is feeding in at the ground level, at the base of what we're doing and our thinking. David.
Thanks for the report, Neil. I've got three kind of areas just to discuss, if possible. So, when we've heard a lot today about kind of difficult decisions being needed to be taken, and often, in my experience, when the NHS is kind of forced into these uncomfortable positions, we can not listen quite as hard as we need to, or we can have a professional arrogance and think that we know what's best for people. So I'm really keen to just understand that as we make some of the really difficult choices that you will inevitably have to make over the next few months and years, that we stay really super focused on people being involved in helping us to make those decisions, because it's so easy to exclude people when things get tough. So just an encouragement there, really. I wonder if you could just give us a quick word on the next steps around the changes at Furness General Hospital, which obviously we know lots of people are very interested in and concerned about. So, you know, where are we at, and what's the next things that are going to happen so that people feel listened to and responded to? And I just wanted to finally just finish by supporting the work around the PPGs. It's for a long time, in my view, been something that we've underinvested in, and wouldn't it be amazing if we could turn this into a really powerful engagement network that reached into, is it 195 practices? You know, if that was mobilised and supported and encouraged and driven, that could be a real two-way flow of communication directly from the heart of our communities directly into the ICB to support you guys to make really great decisions. So just to support that work, and it won't just happen, it will need investment. That we've done lots of work with PPGs in the past, and it's not straightforward, because each and every one is completely unique and different, and so on. So just to support that, really. Thank you.
Thank you. 3 good questions there. I mean, I think on the first one, I think we can make that commitment. That's why we're trying to build this and develop the route through to board. Now, you and I have had this conversation before, David. It's from my perspective, this has got to be the platform from which we start to build our thinking around clinical strategies. So I think I'm right in saying absolutely, and thank you for calling that out. Can you pick up on Furness?
Yeah, and just to come back on that difficult decisions one, I think when we've had examples, particularly where we've got some of those things of service change, our approach is absolutely it is to actively go out and speak to people and actually try and do that in the best way possible. The work around the clinical strategy is drawing out some areas where I think there's some conversations we need to have with the public about changing expectations about the way that they might access care in the future. So I definitely don't think we want to hide away from that. I think we need to do a bit of work to really understand what people's perceptions are, you know, about the way that we might use our investment, about the way that we might provide care in the future, how models might look. So we're absolutely going to be doing more work on that over the next couple of weeks. In terms of Furness General, I can give a broad update. The paper shows that we've published an engagement report from work that we did in November, well, October and November, listening to people, but also working with some of the local communities. The next stage on that is that we're going to be using that insight, and we're developing some work, working with the Trust on developing some of the materials around a pre-consultation business case. As soon as we are able to update and provide an update in terms of that work developing, we absolutely will. And we are actively making sure that we're engaging with the MP, the local communities, some of the groups that have formed from some of that engagement work, and we'll absolutely make sure that we're proactive in updating on some of that. And in the PPGs, I absolutely agree with you. We had a conversation with the Health Watch Network last week around we think there'll probably be a difference from what the practices have told us they've got in place and maybe what you've heard from a Health Watch perspective, and we want to join that up, but we absolutely want to take that appreciative inquiry approach. This is not about saying where things aren't working well. It's absolutely by finding out some really good examples of good practice. How do we support practices to be able to kind of set some of those groups up? But it is with the aim of, can we develop some networks and groups? They're great roots into some of our communities. They're a good starting point. They're not the be-all and end-all of all the engagement work that we want to do, but if we can establish some good links and networks, it will help and support some of that work we do in neighbourhoods as well. So I just fully agree with that. It is an important piece of work.
Thank you. Thank you very much. I've got Chris next.
Thank you, Chair. Thank you, Neil. I suppose it's a really good report on communities and how we're getting that from an ICB footprint. But then I'm thinking about the service user, carer council, patient groups that we will all have in NHS provider organisations, and thinking of the 4 acute and LSCFT. And how do we get the voices from there? So I'm thinking, you know, for me, I've got really engaging and dynamic service user carer council with a chair and sub-chair. How do we get their views from that and the other providers? I think that would maybe just bring a different lens to the report as well.
Yeah, great.
Can I come in that? So particularly from the work that we've started around developing the clinical strategy, what we've been able to do is actually invite a lot of those groups to be part of our, what we call our, at the minute we call it a Citizens Health Advisory Group. It's a group of volunteers who we work with and bring together on a regular basis, but actually we've been able to expand some of that. So we have many of the people who are involved in your local groups are connected to that, and we want to actively make sure that we do that. And I've been along to speak to some of those groups as well to look at how do we connect different perspectives. So we know we've got people in there who are chairs of PPGs or just local people who want to volunteer or take part. But I think that's definitely a route to strengthen some of those people who volunteer, and we meet on a regular basis, and that they actively get involved in different pieces of work. So take, for example, the cancer example, that we've got members with lived experience who are influencing that piece of work, who then come together on a quarterly basis, and we work with that group.
Thank you. Tracy.
Thank you. Yeah, just listening to the conversation, I mean, absolutely agree. This is a really great report, Neil, and it gives that kind of breadth of all the different things that are happening around listening to communities. Really take Chris's point about there's so much more that goes on in hospitals as well, which we haven't captured. I just wanted to just urge board, everybody really to read the Conversations About Cancer report from Health Watch Blackpool. Just a couple of things I wanted to highlight in this. I think the approach that Health Watch and other kind of community-based organisations can take within this is quite different than when a public sector body goes into a community to consult. And I think that's a really important point, that actually we've got so many organisations who are so skilled at this type of work. And this report in particular, this Conversations About Cancer, came to the Place-Based Partnership in Blackpool last week, and we had a really in-depth conversation about the difference that enacting some of the insights within this report is going to make to people's life chances. It's going to save people's lives, let's be clear about it. So, you know, again, I would urge people to read it and think about how do we do more, how do we commission more of this kind of work where we are bringing people with lived experience, we're absolutely understanding their perspective in this, and then making changes as a result of that. I think there are so many levers that we can pull in our communities around this type of work, but all too often I still see lots of investment going into public sector to do work that actually is so much better when it's done at a community level.
Thank you, Tracy. Roy, and then I've got Aaron at the end.
Tracy has commented on a lot of what I was going to say, Chair, so thank you, Tracy, for your comments on that. But it was about Health Watch Blackpool and the work that they're doing, and they're particularly active in the community. And I think Neil would know that. But reaching out to nearly 2,000 people is exceptional, I think, for a start. And as I say, what Tracy has said about Health Watch, many of us know around the table, and colleagues will know, that there has been discussions within government about Health Watch not being there anymore, basically, being scrapping Health Watch, which I think would be the wrong thing to do. I've spoke to some of the colleagues at Health Watch of Blackpool about that position, and they say they would wish to carry on in some guise, whether it was Health Watch or another name, quite frankly. And I think that's really important, considering that the work that they have done, and particularly if we want to commission work from people who are actually able to get out into the community. I think that's absolutely vital that we're able to do that without that being a public, as Tracy has rightly said, a public organisation. These are recognised people by recognised as very confident of going out into the community, knocking on doors and getting answers from people, and I think that's the people that we need to continue to help to try and do that. Thank you. Thanks, Neil.
Thanks, Roy. Aaron.
Yeah, thank you, Chair. It's a really important agenda, this, for us, and I'm just trying to pull out some themes, because we talked, didn't we, as a strategic commissioner in development, the importance of using evidence and data to inform the decisions that we have to make. You know, we get a lot of money, don't we, to deploy to best effect for our communities. So there's just some lines of inquiry that open up here with the report around why is there such disparity of the patient participation groups across the patch? Some really well represented and some not. What does that mean? Are they not seen as valuable in some areas? And I do think there's something about the so what. So it'd be great to get them all to 75% and 25 members plus. Would it? I don't know. What changes as a result of doing that? And one of the things I'm curious about is the ICB is a group of so many people with a lot of autonomy and a lot of responsibility, but we can't possibly respond to 195 practices, patient participation groups, conversations. And I could find us spending 3-4 hours on all individual bits of feedback from different areas of the communities we serve. And that's good as a board story, but you can't make strategic decisions like that. It won't allow us to do that. We'll end up with hobby kind of narratives. So one of the things I think we need to be clear on is, again, how much autonomy and responsibility and control do we give out from here to places and neighbourhoods to allow them to create their own opportunities with their communities, whether that's through PPGs or any other construct, with an outcomes-based conversation, rather than we're going to hold everything centrally, we'll convene you, we'll bring a network together, we'll do. I think there's something in the body corporate about sharing across the system. We need to do that strategically. But I am keen to explore what local and place development looks like in these kinds of agendas, Chair. And to David's point, I think really good questions. What I'm noticing with some of our engagement work, and I'll use Furness General as an example, is lots of engagement, lots of listening, but that doesn't necessarily mean that everyone's opinions are going to feature in a decision. There's a difference there. But I do think we need to get better on the you said and we've done. So been heard, considered, but here's the reason we've made a decision and what we've based that on. I think we're poor at the feedback loop rather than just putting on an event and then people come away and assume something's going to happen with what they've said. So there's just some pieces to explore as a board, I think, in our strategy going forward, because I could see us getting into quite deep tendrils of support and resource and asking for feedback, and I think it would clog up the board quite quickly, Chair.
I think that's a really important point. Thank you, Aaron. David, I can see you want to come back.
Just two points. There's something about us having a kind of repository of intelligence from people, isn't there? So I take your point, Aaron, we can't discuss every piece of feedback that comes from every group. I think that's absolutely right. But what we can do is pull all of that together, probably in really smart, modern ways, and take from that the learning and, you know, kind of themes that come from our communities. and I can't remember my second point, but if I do, I'll come back to it.
No, no, thank you. Okay, so good conversation. Yes, Debbie.
Sorry, Emma, I need to get better at waving, don't I? It's a similar point, really, because I noticed in the report there was mention of gathering some principles through us drawing communities together. So at the start of the report, Neil, you talked about how there were some really clear principles coming through when you'd done the analysis of what we've heard in the past sort of 2 years. And I guess where my mind starts to stray is when at the end of the year we want to evaluate how well we've engaged and involved the public and what impact it's had and what the outcomes are as a result of it. I'm still not absolutely clear what framework we've got to be able to sort of come to that decision and form that judgment. So I think what we're doing is we're getting a really rich picture of interventions and listening and actions, but I'll be really interested to see how as a board we form a judgment at the end of the year about what we've done holistically and strategically and whether it has made the outcome and the impact in terms of commissioning that we would want it to, or if there's anything else that we need to listen or learn around it.
Yeah,
So it's a big sort of point, but it was just a reflection, I think, that your really helpful report led me to, particularly at the start.
Yeah, I think. Do you want to come back on that?
I think the important piece of work is some of the stuff we're doing around the commissioning intentions. So Aaron is absolutely right. We're engaging on some quite specific things, sometimes because there's a legal requirement for us to do it in the best way possible. And we could just do that and think about some specific issues. But what we've done is drawn out what are those really common themes that we hear repeatedly about experiences that people have. And not just around some of the engagement involvement, but also some of the stuff we receive through our patient experience team as well. How do we feed that into the things that the public are saying are really important to them, particularly around the way we go about access, the way we go about community care and the way things might be provided differently locally. And Craig's team has done a really good job of making sure that those key themes have been really looked at in the way that we've developed commissioning intentions. So are the things that we're looking at going to meet some of those things that will satisfy some of those key themes that are coming out of the public? So there is a huge amount of work that sits underneath that we've embedded into the commissioning intentions work, and I think as that develops you'll see we have done some very specific stuff, but we've drawn out some of those key themes to make sure that actually we're not recommending things for our commissioning intentions that are detrimental, but also identifying areas that we know we're going to have to engage with the public on things where we need to manage and change expectations, because sometimes some of the things that the public want might not necessarily be the things that align some of that clinical evidence and how we want things to be in the future. So that really influences the way we engage and involve people over the coming months around what a 5-year strategy might look like, or what are some of those common principles in the clinical strategy. So I think it probably answered through some of those pieces of work, if that's helpful.
No, I think that's right. Okay. Is it you've thought for your second thing?
I've remembered my second thing. Sorry, thank you. I don't know, it must be an age thing maybe, I don't know. Engagement must be really carefully planned, and there's a real danger, isn't there, to us listening to the loudest of voices. And, you know, if we make decisions just based on that alone, we will be making the wrong decisions. So, you know, there's some really amazing examples of where we take a very contentious issue and we plan carefully engagement, and actually what we hear back from a much broader population base is something very different than what the loudest voices in our communities might be saying. So we've got to listen to everybody, but we've got to plan engagement really, really intentionally, I think.
Thank you. It's good discussion. I think there are a number of things that Aaron and I are going to take away to think about in terms of bringing things back. Okay, I'm going to move on now to the Quality and Outcomes Committee Escalation and Assurance Report. Sheena.
Thank you very much. And as usual, I will assume that people have had the opportunity to read the report. A couple of things I just wanted to pull through, and the first of those are around the alert areas. And the first of those is patient experience and complaints report. So as we're a Quality and Outcomes Committee, we clearly look at the themes from patient experience and complaints report, and that's particularly important when we look at our integrated performance report, because that triangulation of different areas to understand what is going on in terms of the care that we commission on behalf of our residents. And what I just wanted to pull through was actually something just that we had noted when we were looking at this report, was around we still unfortunately have a backlog in our response to complaints, and so we considered clearly that obviously has an impact on patient experience, but also slows down our ability to look at our themes and take our learning from that. So, and we note that that is due to the pressure on the team and you know, some of the challenges we have there in terms of numbers and that impact obviously on well-being. So in the short term, we're very pleased. This was actually, if people remember, escalated a wee while ago to the board, and action has now been taken through the executive management group in terms of thinking about how we can support the staff there and work to recruit people to the team. That's the short term. In the medium to longer term is to take a step back and to think about what's the best way to actually respond to patient experience and complaints, and how do we do that on a more sustainable footing going forward. The second area I just wanted to note for members was around the integrated performance report, and as you know, we are now looking at that in terms of the performance but also the outcomes perspective, and the thing that we wanted to pull through today was the challenge that we can see on the waiting list position, and I know that I'll probably have a greater discussion when we get on to considering our integrated performance report later on the agenda this afternoon. And then the final area and report is around we have oversight, obviously, from the Quality and Outcomes Committee in terms of our work on all-age continuing care around the quality aspects, finance performance, look at the impact of the waste, the way that we're trying to get better value from our work that we do in that area. So we're obviously looking at the quality aspect of that. And what we noted there again was some of the challenges that we have around levels of sickness and the work that's going on the organisational change there. And what we were seeking mitigations and assurance on that was around, again, additional support to staff, and you'll see that in the actions there. So that's something that we're keeping a weather eye on. The final area I just wanted to bring to people's attention really kind of loops us back to earlier on the agenda this afternoon, and that's on the assurance bit. And we're just bringing the assurance bit there, the work that we have done in terms of looking at the risk management report and the work we did in our committee to consider that. And I think that's all I wanted just to bring to members' attention. Thank you very much.
Thank you, Sheena. Are there any questions to Sheena? No. I'm going to move on then to the integrated performance report. Asim.
Thank you, Chair. So I think the integrated performance report is important that we set the national context first. So as Sheena has alluded to, there is real pressure around waiting list and a real focus nationally from the government around waiting list, where we saw following the pandemic, nationally we had 4.5 million waiters. After the pandemic, now we have 7.4 million people waiting on the waiting list, so significant pressures. So across England, waiting lists remain historically high, and NHS across the country is managing sustained demand, workforce shortages and pressures on hospital capacity. So the challenges described in the report are not just unique to Lancashire and South Cumbria, and they are being addressed both locally and nationally. At the last board meeting, I covered in detail the increasing demand, the number of the sort of record number of referrals we are seeing coming into our hospitals. And in this report now, we have a section that looks at that demand, and we'll improve on that in future reports. So I think that context is important as we go through the report. So I will start with elective care and waiting list, and with a focus on our progress with the longest waiters. And this is going to be a major focus of this report and a major focus of the remaining months of this year. So elective care is when we talk about planned operations and outpatient treatment. Even with that pressure I've described, what we have seen in terms of overall waiting numbers from September 25 to November 25, in a 2-month period, we saw a reduction of 5,500 people on the waiting list. That is with increased referrals, and that's testimony and testament to all the workforce and our frontline staff that are working really hard under these pressures. In terms of our really long waiters, the last report, which contained data for November, we had 127 patients waiting for more than 65 weeks. November 23, a couple of years ago, we had 2,500 people waiting for more than 65 weeks. Our expectation is by the end of this month, we'll only have 13 patients waiting for over 65 weeks across our 4 providers and our independent sector. So recognizing what Sheena has said in terms of our longest waiters, we can see significant progress in terms of what we are doing. And this is reflected by prioritization of our longest waiters. And it has been made possible through a number of interventions and through national support. And this national support is continuing for the remainder of this year. So NHS England are providing additional support for our providers to do additional activity. Our focus now moves on to the 52-week waiters with, again, with the same mandate on how do we eliminate this. And we, again, have seen really good progress around our 52-week waiters. Just to demonstrate the sustained improvement, in November 23, we had 11,500 people waiting over 52 weeks. Last year, we had 7,000, and by the end of this month, we're predicting 5,000. So I think this is showing that we are doing the right things to reduce our longest waiters. And also from a health inequality gap, which the report now includes as well, which is important, we have seen the equity gap between the most and the least deprived population has reduced from 2% in July 25 to 0.7% in December 25 for our people waiting over 52 weeks. So moving on to cancer performance. So our cancer performance has improved since the previous reporting period, and I'm pleased to say our current data is now showing that we are meeting the faster diagnosis standards. And to remind the board and the public, this is the standard where cancer is ruled out within a 28-day of referral, which is set at 75%. And we are also just about meeting, we're 0.5% below the target, around the 31-day treatment standard. And this is a decision to treat for cancer target. But the 62-day target remains really challenged, as it has been throughout the year. In addition to these targets, I've covered previously and quite extensively the importance of early diagnosis, and this is critical as it improves the outcome for our patients. It reduces the intensity of treatment required, and it also helps services meet the waiting times. And we heard the patient story today around cervical cancer screening, and that is showing how the impact of that will be on our waiting list and cancer performance. Because cancer performance is not just about hospital treatment, it's about access, awareness, and also the trust in services. We also heard about the impact on different communities, and I think it's also important to understand the intersectionality of different areas that will impact on inequality. So it could be women health, it could be deprivation, and it could be ethnicity. So all of these things need to be understood in terms of our response, in terms of how we provide appropriate community and culturally sensitive services. So the last couple of sections, the area I want to highlight is primary care. And the report demonstrates the challenge in primary care, and this is not a new thing. We have reported this consistently across the year. So primary care, and particularly general practice, is seen as our front door. And our data tells us that people are living longer and people have more longer term conditions, and this absolutely will then have an additional pressure on our GP practices, who are seeing more appointments, more complex health needs, and more follow-up of care. And I think it's important that we be open about our workforce challenges. Lancashire and South Cumbria has one of the lowest numbers of GPs per head of population in the country in terms of GPs. This means that compared to many other areas, we have fewer GPs available for the size of our population, meaning higher workloads for existing GP team. But saying that, our GP practices continue to deliver very high levels of care, supported by wider practice teams and additional roles like physiotherapists, pharmacists and social prescribers. I'm just going to finish on our mental health services. And I'm pleased to say, and Chris has covered this many a times, and since I've been presenting this report, we have seen different numbers around out-of-area placements, and we have currently 0 people in inappropriate out-of-area placements. And I think Chris has articulated this previously. It can just be seen as a number that we have 0, but this is so important to the outcomes for our population and people. An out-of-area placement is where a mental health patient is sent out of area, and this is not good for their recovery. It sometimes isolates them from their support networks. So this is a great achievement, and again, sustained improvement. This time last year, we had 19 inappropriate out-of-area placements. So I will leave it there. UEC will be covered by Craig in his winter report. But I just want to say before I finish and open up for questions with support from my executive colleagues, is what I've covered there is some of the headlines where the challenges nationally. The report, as you see, covers now children and young people. Yes, there's a bit more work to do around community services. That gets discussed in detail in the Quality and Outcomes Committee, which we need to find a way of bringing that into this report, because it's not just about elective care. There are many other people waiting in our system that don't necessarily get talked about because they are non-consultant-led services. So I will pause there and happy to take any observation and questions. Thank you.
Thank you very much, Asim. Questions for Asim? Okay, so I've got Tracy, and then I've got Jane, and then I've got David, and then I've got Steve.
Thank you. Thanks, Asim. I think something I've taken from your report is that there are lots of things moving in the right direction, but still a lot of challenges. And I just wanted to pick up on the 52-week wait and the fact you said it's reduced to 5,000. We're expecting it to be 5,000 by the end of this year. This month. I think, you know, we've had these conversations before, but behind those statistics are people, a lot of people. And the people who can't live their lives because they're in that hiatus of waiting for something that's going to hopefully improve their condition. I'm also really mindful that the people who can't get out and about, but they're probably people who are going to the GP a lot more as a result of waiting. But also going back to a conversation before, I think Jane mentioned Get Lancashire Working. There are also people who can't work in many situations. So I just wanted to emphasise the importance of reducing these waiting lists for people in the round, because actually this isn't just about the health and care system. This is about a much wider way in which we're improving things for individuals, but also on a kind of an economic footing as well. And I know there's a real challenge across the country, particularly since the pandemic, of people claiming disability benefits and then opting out of the workforce long term. And I think this statistic goes hand in hand with some of the work that happens across other sectors where we're trying to encourage people to move into work, but very difficult to move into work when you're waiting for something that's going to actually make a difference to your life.
Thank you, Tracy. Jane.
Thank you, Emma. Asim, in your summary under elective recovery, you say the patient cohort aged under 18 are experiencing longer waits on average than the adult population. And I kind of read that and thought, you know, just how serious that is, that, you know, children and young people are having to wait, you know, a long time for treatment. And I wanted more of an insight into it, if you can provide one. Is that an issue of supply and demand, in the sense of our demand's increasing and we can't meet it? Is it in certain areas only, specialty areas or geographical areas? Or I just wanted to understand that a little better, if that's okay.
yeah, if you could, yeah.
Thank you. I think just on Tracy's point, I think really important question, and I think there's a triangulation with what you're asking and some of the deprivation, hence the inclusion of deprivation in the report, because sometimes it's the people in them areas that have to take time off work to go to their appointments, and if things get cancelled, then they causes real issues around that. So that triangulation is really, really important, and I sort of covered some of that in terms of it's not just deprivation, it's other areas, and that's the kind of thing we are really wanting to get behind in the Quality and Outcome Committee. And it's clinical prioritisation, there's waiting well, and all of them kind of initiatives go hand in hand with that. In terms of Jane, in your point, I will come back to this probably in a bit more detail at the next board meeting. But in terms of the data we have seen, it's a sentence, yeah, but it will have a lot behind it in terms of, it'll be speciality, it'll be geography, it'll be certain areas, but we will bring that back in a bit more detail. I've not got that in hand in terms of pinpointing which area, but we have done the work around that. And again, that will also include deprivation. So there's the age profile, deprivation, and they'll also include some of the other areas around sex and male, female. So we'll bring that back in due course. Thank you.
I'm thinking, and I was trying to catch Sheena's eye, would that be something that we could...
Yeah.
I think that would be something that would be appropriate for the Quality Committee, isn't it?
Yeah, we are, as Asim has inferred, we are really trying to get behind the waiting list bit. So for us, it's a so what question, and it's, obviously people around the table, that's where people's heads are getting. So it's not just the numbers thing. What does that mean for people? And what do we need to do to ensure that we think about responding even more effectively to the needs of the population? And so that's something that we certainly want to pull through even more. So we will make sure that comes back around. Thank you, Emma.
Emma, just on that, there's already an action for the next Quality and Outcomes Committee to do a deep dive around elective weights, looking at all of them inequalities, and what that will show, it's very different across different specialities.
That's really good. So actually that addresses a number of the points that have been raised, because I'm very keen that we focus on what we're going to do about it, as opposed to surveying the problem. David.
Thank you. Thanks for the report. Just two areas just to kind of look at a little bit, please, if we could. The access to primary care is obviously incredibly important to our population, and I just wonder whether we have any idea of what the trajectory might be to get us back to a place where we have the appropriate number of appointments. To hear that we're performing worse in other areas is tricky, but I guess our public will want some assurance that we're doing something about that, and by when. And then the second point is about, I just kind of want to pick up on a point that Denise was making earlier around continuing healthcare. I'm carrying a level of concern about the changes that we're making to continuing healthcare, and this is a highly contentious issue. We've discussed it many times over the years in the board and other places. But what I get the sense of is that the eligibility criteria has been adjusted, and what that will mean is that people will be becoming ineligible for continuing healthcare, at which point presumably they end up with a local authority, which obviously is really stretched and possibly has tight criteria as well. And ultimately what we end up with is people not getting the support that they need. So I'm anxious about that. I'd like to understand more about it. And simply if one part of the system contracts, we can't just push it somewhere else and expect that it's going to be met. What will happen is people won't get the support that they need, which will have a massive impact on their lives. I understand the financial challenge in both sides of the system, but at the heart of it is a patient probably not getting some of what they need in terms of living a great life.
Thank you. I'm going to bring Jane in on the CHC. Is that... Yeah.
Thank you. Thanks, David. I hear your concerns, and these are concerns that I think we've heard from various bits of the population, carers, friends, family, and service users themselves. The first thing to say, really emphatically, is The decision-making tool, the checklist and the framework for determining eligibility for continuing healthcare is highly prescriptive. We are not permitted, nor would we seek to amend that in any way. We were outliers benchmarked for population for the proportion of spend, and the proportion of spend overall was bigger than expected for a population of the size we serve and the demographics of that population. There was also some variation within the spend, so the different categories. We have a facility called Fast Track so that we can rapidly provide somebody with complete continuing healthcare nursing care towards the end of their life. We had some instances, quite a number, where that payment was applied, the care was provided and wasn't reassessed in a timely way, and some people were in receipt of that payment for really quite a number of years when it was supposed to support end-of-life care, and it wasn't properly reassessed. So I don't think that the challenge around eligibility is founded. I think the challenge of the experience of some people who've maybe been in receipt of funding that has been reassessed correctly and brought back into the framework descriptors is well founded, and people experience that with some difficulty, but we are properly working with our partners in local authority and with family groups and with carers and patients to address that. I do think it's true to say that with some partnerships that we've engaged in recent times, we've had to we've done an oversteer, and we've had to course correct and bring our compassionate decision making around CHC properly in line with the spirit of the framework, and that has been welcomed by patients and families. We've had some good feedback and some good commentary back from our local authority partners. So I just need to be really clear, we have not amended the eligibility of the framework. We're not permitted to do so.
Thank you. Forgive me, I was writing when you made your first point. Do we need to come back on that?
It's about primary care.
Primary care.
I don't know if Andy...
Andy, can you... Do you want to... do you mind repeating it, David?
Certainly.
Thank you.
Yeah, my question was around when we can expect to see the kind of, the appropriate levels of primary care appointments in the system. If we're an outlier, we're presumably doing lots of work to improve the position. So what's the trajectory?
It's a good question, one which I will honestly need to take away, David, and come back to you on. What I can say is it's not the same across the whole patch. And I was actually at Edge Hill University at a primary care conference on Tuesday with some professors of primary care, and we were looking at the data actually in the exponential increase in primary care appointments that have happened over the last 5, 6, 7 years actually in a way that hasn't happened across the rest of the system. So if you actually look, although the headlines are very huge about UEC attendance and elective admission or non-elective admissions to hospital, if you take a longer view, the curve has been not very great in terms of its increase at all, but if you look at the curve of the increase in primary care appointments during that time, it's been absolutely huge. So longitudinal data tells us a story about primary care across the whole patch, which is quite alarming in terms of the number of primary care teams that we have in place. So that's the first thing. The second thing is to say that there are some brilliant examples in Lancashire and South Cumbria where things like modern general practice and total triage are being used in really, really effective ways, which means that actually we've got rid of the 8 o'clock queue, either physically or on the telephone, and patients are able to put their points through online, answered by a clinician first of all, to make sure that they get exactly put into the right kind of appointment by the right person in the right place in a way that suits the individual contacting the practice. We use that in my own practice, for example, and patient satisfaction rates are very high as a result. And I think it's about using some of the technology that's available and working well in some parts and spreading that learning across the whole patch. I would like to have a little bit more of a look at the data with ASIM, and as part of our clinical strategy, it's one of the things that we'll be developing very and actually our neighbourhood schemes, both in South Cumbria and in Morecambe Bay and in Blackburn with Darwin over the next 6 to 12 months. So I'll come back to you with an answer, but it's not a uniform picture right now, and there are some phenomenal examples of good practice which we are really keen to spread and take an improvement approach to.
Thank you. I've got Steve next, but were you coming in on the back of that conversation, Julie? So I'll let you come in briefly and then I'll take Steve, and then I think I'm going to come to Aaron and move on.
Thank you, Chair. I was just reflecting on some of your points. General practice, I think we also suffer the same element of what urgent care is that, is it the appropriate location for the query when we have in primary care a lot of other options? We have wonderful Optom, wonderful dental, pharmacy, and a number of self-help resources. So it's about making sure that it's the right place to direct people. And I suppose that's the subtlety of the report. Talks about GP appointments, and our teams are vast. We have a massive range of skill sets, and it's about making sure the person sees the right skill set. So I think sometimes when we talk about GP appointments, there are definitely people where it is useful for them to see a GP, but it may not be exactly the right thing for them. And then there was just a reflection back on the waiting list, is that as Tracy pointed out, we see on repeat a lot of people who are sat on a waiting list, and that is an expression of the frustration and the lack of movement on that waiting list. But then, of course, it then means there are then less appointments for people to enter and hopefully be, deflected is not really what I mean, but, they only require primary care. And so I would urge that I think as a system we need to look at people who are on waiting lists not as a rolling desert, as a population that we could actively manage, and that might sit with the trust, it might sit with the community, but I think as an organisation, as everybody involved, we need to try and keep those people waiting well, and potentially in work, because we see a lot of people falling out of work whilst they're in the waiting list. Thank you.
Thank you. Following on, do you mind, Steve? I'll come to you.
Sorry, I just got excited. I wanted to answer straight away. Just let me give an example of some of the work we're doing on that exact example that Julie's just given. So I chair and am the SRO for our neuroscience programme. When we've scrutinised the data of people who are waiting for neurology appointments, and the appointments are long, 30% of people waiting on that waiting list right now are on the headache pathway. Over 90% of the people on that headache pathway absolutely do not need to see a neurologist according to the data when we've looked through it. And they're waiting to see a neurologist, but actually a headache pathway has been developed now, which means really they could be seen by someone else completely, and sometimes just basic interventions haven't been made first in line with best guidance. So we've developed a digital solution with the help of our CCIO, William Lum, which will be rolling out with fantastic brand new guidance into primary care, making sure that actually all the different parts of a pathway have been thought through before a referral even ever takes place. And what we should see is a massive decrease in our waiting lists by better use of AI, better use of technology, better use of guidance, better use of knowledge within primary care, first of all, thanks to the great help of Suresh, one of our professors of neurology at LTH, and the pathway that we've co-developed with colleagues in primary care. So there is really active thinking of how we're looking at some of our waiting list problems and how we apply really good clinical acumen and innovative solutions to some of the issues we're facing, and that's happening across our clinical pathways.
Great, thank you very much. Steve, finally.
Thank you, Chair. So, Asim, or maybe Chris, congratulations on getting the mental health out of area numbers down from 19 to 0. That's 19 people who are being much better served than they would have been. And I see elsewhere that this is a bit of a scourge in the mental health services. But how has it been achieved? And is it sustainable, or is this just a point in time?
So I think it's multifaceted. I think there is specific work that we've done as a system around clinically ready for discharge, and that's with Craig's team and with local authorities and some joint posts, especially within Lancashire County Council and ourselves at LSCFT, around really making sure that when patients are ready to be discharged, there's the facility and the placements for them. I think there's the set of work that's been done before admission. So what's the purposeful admission? Why is the patient being admitted, and can that care be delivered by home treatment teams, by community mental health teams? So we've seen reduction around admissions. And then looking at the pathway work, so you'll see in the report length of stay is continuing to reduce as well. So I think it's a reduction on categories from admission. It's reducing that length of stay and that real focus on clinical pathways. So specifically looking at complex emotional needs pathways, psychosis pathways, but then also actually what can we do as a system and how can we stimulate the market to make sure there's placements for patients when they're ready to be discharged. But also looking at some of the housing constraints that some patients want. They've been inpatients in mental health, they lose their tenancy while they're in hospital. If there's a forensic or arson history due to illness, some housing associations won't accept. And so how can we as a provider, and working with housing associations, provide some of that additional support? So multifaceted, it's not been easy, it fluctuates, but it's definitely on the right track, and it's so much better for patients.
Thank you. Aaron.
Thank you, Chair. It's a similar theme I'm drawing to today, which is the difference between, I guess, an update on some quite transactional weekly, monthly targets and our role as a strategic commissioner, which isn't about performance management of individual targets. We have a responsibility to commission effectively services that mean these things will improve for our communities, and it's very difficult to draw a connection between the updates here and trajectories of improvement, the commissioning intentions supporting the change, and how assured as a board we will be that those actions are going to be delivered over time. So one of the things, again, Chair, I'd want to explore is, as we inevitably in this quarter now, it's become quite transactional with ourselves and the providers thinking about capacity, finances, kind of how do we get that demand and supply connection to get the numbers moving. But actually, some of the work that Craig has been leading on with the team over the last couple of months a bit differently is our commissioning intentions are now focusing quite purposefully on growth reduction, demand management and alternative access pathways for all the reasons that you've articulated, Tracy, that people waiting a long time, there is a big impact on other parts of the service and those individuals. So, you know, I'm sitting here trying to draft like what's our cancer strategy and cancer plan around broader term cancer improvement to make sure these work. What's our estates investment plan around diagnostic capacity and making sure we've got good quality local access. I think we're missing a few strategic connections on the so what narrative, and the so what isn't where are we next week and what's the performance report going to look like. It's how do we zoom out as a strategic commissioner and make sure over the 3-year plan we're really confident that what we're doing is going to lead to step change reductions in some of the poor performance we're seeing at the moment, Chair. So just make the point, we'll see it in the medium term plan, but if we're going to see individual actions here to come back next month through our assurance committees, it's not the right approach.
No, absolutely not. And I think we've successfully avoided that. But it is. We are in a. Yeah. I think that's a helpful challenge to rise. These things will be here for the next period. We're in that lacuna while there's an awful lot of work going on behind the scenes. But we are therefore looking at performance reports in a slight vacuum, aren't we? Okay, so I'm going to move on now to the Finance and Contracting Committee Escalation and Assurance Report from Steve.
Thank you, Chair. In terms of both the reports, which are month 7 and month 8, which relate to October and November, I think I'll take the reports as read. They give an indication of some of the broader issues that the committee deals with, but I want to focus on the money. That seems to be the key issue in the system at the moment, at the current time. And particularly in terms of the ICB is currently stuck under a set of undertakings, financial undertakings related to the Recovery Support Programme. And I think the desired plan strategy is to get out from under this by the end of March of this year. But to do that, there are some significant deliverables that have to be progressed over the coming weeks and months. If you look at the common themes of those 2 reports related to month 7 and month 8, which by their very nature are historic at this stage, you know, the key costs which are really the focus of attention, all age continuing care, prescribing and the overruns in the independent sector, all of which added together relate to significant pressures. However, there are substantial mitigations to manage those. And I think that's the first point I'd want to make in that from month 7 and 8, what was clearly identified was a substantial enhancement in grip and control by the ICB, by colleagues in the executive, on the management of those costs, but also in terms of the quality of the underpinning information as well. The quality of the reporting, I think, has improved significantly over recent months, and that helps the quality of the conversation at the Finance and Contracting Committee. So I think I'd just like to say I'm grateful to Mark and colleagues, both in Finance and indeed Nancy and others in AACC, for the work they've done to enhance that reporting throughout the course of the year. It doesn't make delivery any easier, but it does make our capacity to have those conversations easier. And really just to report, I was at a different event a couple of days ago with Stephen Hay and Chris Adcox, who both commented, without prompting from me, favourably about where the ICB has got to with all of that. So having that, I think, perspective from the region, I think, is pretty helpful. But nonetheless, I think we need to continue to work on those cost recovery programs. I've mentioned the enhanced grip and control. I think there are some green shoots in the month 8 report, but we really do need to look forward to more of those green shoots flowering in months 10, 11 and 12, because the proof of the pudding with all of this is the delivery. And that's what we need to see, and I think we're looking forward to, as I say, I'm cautiously optimistic at this stage, but that will be the key as we go forward. So I guess the key messages for me are better reporting and quality of information is undoubtedly in helping the conversation. It's clear that the executive have grip and control, but it is a very difficult set of issues to continue to manage and will continue to be a challenge through to the course of the year end. But on that issue around the year end, the 31st of March, it's an accounting construct. It doesn't really exist in real life, other than it is a day. But values of buildings don't change day after day. But there are some risks associated. I think the first is about making sure costs are in the right period, and pushing back on individuals who, for their own interest, might wish us to move costs from one year to another. 26-27 is going to be an incredibly challenging year. So it's important not only do we focus on getting to 31 March, delivering those numbers we've said in terms of plan, but also making sure that we resist anyone's challenges to move cost into 26-27. It is going to be difficult. The other thing about 26-27 is we're going to have to transact the challenges around moving the operating costs for the ICB to the £19 a head. So that's another £35 million of costs that have to be managed out of the project, and the least other costs we have coming in there, the better. And the last thing is, I've talked about cost reduction programs for the current year. We need to make sure that we also focus on 26-27 and beyond. What we can't do is get 3 months into 26-27 and play catch up. So we've got to be ready to deliver that from day one, which means we are need to be working on those cost reduction programs now. So I think my quick analysis is cautiously optimistic, really recognising the tremendous work done by the executive in some incredibly difficult circumstances as well, bearing in mind the transition for the ICB, but head down and crack on with delivery. So I'll happily take any questions.
Thank you, Steve. I think probably, should we take the finance report and then combine questions? Are we? Yeah, I think that makes sense.
Thank you, Chair. I will just briefly set out the detail that Steve's alluded to. So this is the finance report for month 8 within the financial year, so that takes us up to November. As you can see from the report, I will just pick out some of the key numbers just to make sure colleagues are all up to speed with the current position. So as at month 8, the system, which is a combination of the NHS provider and the ICB, is 54.2 million behind plan. So that manifests itself as a 78.7 million deficit against its year-to-date plan deficit of 24.5 million. Within that, obviously, you can see the breakdown in Table 1 in the paper. The ICB reporting a break-even position and provider trusts with a negative position against plan. The detail of that is largely down to shortfall on the delivery of efficiency savings, which again you'll see some information within the pack, with recovery of that expected during the latter part of the year. Some of that is profile issues, but some of it is, I suppose, the delay of implementation of some of those savings for a number of reasons, which again I know we've spoken about previously at board and indeed at committee. I'm going to spend just a couple of minutes digging into the ICB position. I will focus again on a couple of the key areas that Steve's already alluded to. So again, we are reporting a balanced position in both the year-to-date and the forecast outturn, but again, to Steve's point, there is a lot of risk to be managed in the last 4 to 5 months of the year in order order to meet that break-even position. Again, in the report, you will see some detail of the programme areas. The main areas remain as consistently reported over the last few months. So to name 3 or 4 of them, so contracts performance across both the independent sector and the NHS providers to some degree, costs in relation to mental health and learning disabilities and autism, packages of care, continuing healthcare as a wider sort of pooling of costs, which again we've alluded to today, and indeed prescribing expenditure, some of which again you'll know is in relation to both some of the new drug pressures that we've got and equally some of the sort of international market which is driving some of the costs in the local system. Again, there's more detail of that in table 2 within the report. We are obviously at the point now where we're looking ahead to the end of the year with a lot more detail, again to Steve's point about landing year end. So again, we use that information on a monthly basis to now develop a sort of a risk-based report, assessing that against a range of scenarios, trying to come out with the range by which we think the position will look. So as at month 8, again, there's a little bit of terminology in this. The most likely forecast, so that again is based on these assumptions, would suggest a potential deficit of around 14.5 million. That consists of a gross risk of just over £70 million, but with mitigations already identified around £56 million. Again, you can see the detail of that in table 3. I should be clear that doesn't mean obviously we're going to end up with a 14.5 million deficit. That means that based on those assumptions, that's where we think that would take us to. But either side of that most likely case, as you know, we've got a best and a worst case. Again, we're judging those assumptions on that basis. The work of obviously the executive team and the wider organisation then is to make sure that we are both delivering the efficiency savings, of which some of that risk is in the 14.5, but equally identification of further mitigations to close that gap. And again, that gives us the confidence, I suppose, to report the break-even position that has just been described. There is further information in the pack on those mitigations. Again, I would point to 2 or 3 key areas, so particularly continuing healthcare and the improvement plan that, again, is very well trailed through other parts of our organisational structure, so Quality Committee, Finance Committee, etc. And again, some real good plans there, but does need delivery in the latter half of the year. And then some of the areas of volatility, which again ICBs are used to, so again prescribing and other operational cost pressures, which again has been featured in previous reports. I just do want to bring to your attention, however, that the 14.5 figure does exclude a couple of issues, again, just for absolute clarity. So, in particular, the voluntary redundancy scheme, which again we're still working through. We've got some assumptions in our sort of outturn position, which is more than the allocation that we've received, but obviously we're working through the implementation and implications of that at the moment, and also any implications of any wider system issues, such as the deficit support funding, which again you'll see referred to in the pack, and we're in live conversations with NHS England about the remainder of the year and how that may play out. I'll finish up just by saying, obviously, there is more information in the pack regarding efficiencies and capital. Happy to take any questions on either those or the earlier points, but I just asked the board at that point to note the position as at the end of November, and obviously working with committee chair on the detailed reporting as described to make sure we do provide the right level of information. Thank you, Chair.
Thank you. Thanks, Mark. Thanks, Steve. Any questions for either of them? Tracy?
Thanks, Chair. Just a few points from me. I think at the last meeting, I asked a question about us sort of backloading some of the cost savings around the recovery support. Sorry, the waste reduction programme. The report does give a bit more of a sense of that, but I just wanted to kind of pick up that point again around: are some of the schemes that are in place not actually delivering some of the cost savings, and are we expected to see more over the next 4 to 5 months? With that, will that then result in, and you've talked about, and the report talks about the deficit support money and the recovery money, does it jeopardise any of that money that comes down if we finish in a worse position than predicted, I guess, is one of the questions. And the other one is, the report talks about an underspend on capital. Could you just clarify that and what plans there are, I suppose, around that if we're looking at a capital underspend? We obviously don't want to lose that money, so what are we doing about that?
Thank you. Thanks for the questions. Share your, I suppose, concern, about the backloaded nature. I'm trying to talk into the microphone here, so bear with me.
absolutely right, and I think we had this conversation last time round. You know, ideally, you'd start the year with a fully recurrent plan. You would have a plan that's profiled equally to some degree, but you know, in a better proportion. I think the symptoms of this financial year are partly as a result of some of the delays last year's planning rounds, the contracting guidance and other issues. That said, we are, to Steve's point, aspiring to be a lot further ahead this year, and I think albeit we're all wearing the scars at the moment of the difficult challenges in the planning round and the timescales that we have, it is much, much better to be doing it now rather than, let's say, in February or March time, so we give ourselves a fighting chance of, again, to reiterate Steve's point, you know, landing on the 1st of April with a fully developed plan, and we all know what we need to do. So a little bit of the symptom of the architecture that we headed into in 25/6, but we could certainly have helped ourselves, I think, in terms of a longer term set of efficiency and savings plans. I think, again, this year we, as you know, we're having to submit 3-year operational plans. So again, trying to move away from that annual planning round into a much longer term. So how do we use sort of the pipeline of savings and opportunities in the way that we normally would to give ourselves the best fighting chance of doing that? So there are definitely some lessons learned. I suppose to dig into your question a little bit more, you know, we knew that some of our areas were risky in terms of our efficiency savings plans, and I suppose some of that is now playing out in terms of the numbers. However, through our internal systems and processes, so we have a weekly meeting that, again, are in chairs where all of the senior programme officers, the exec team are, you know, scrutinised in terms of recovery of those WRP plans, and where we can't recover them, where are the other mitigations and other opportunities. So, again, I think we do have the eyes on the challenges that we have, and we're trying to find other ways to close that gap, and hopefully over the, you know, the last 4 months in the year we will find ways of doing that in order to deliver the position. Second question was around deficit support funding. So there are definite risks in that. We're not the only system who are struggling, I suppose, a little bit with the mechanics of deficit support funding. It is a non-recurrent and uncertain income funding stream, perhaps, that we would like to not have, but that's the architecture that's been designed. And I fully understand and appreciate why that mechanism is in place. It does give us some technical and operational challenges in terms of the way the funding flows and the decisions that sort of come from it. And certainly on the provider side, and certainly a couple of colleagues around the table will be able to talk to, you know, the challenges of cash regime at the moment, and the way that you know, that does impact on providers, particularly in terms of drawing down cash and withdrawal of deficit support funding. What does that mean in the relative short term? Again, we're trying to work closely with NHS England partners on deficit support funding, and indeed how can we improve that going forwards. I should stress it is a feature of the 26/7 sort of regime as well. So, you know, again, we need to learn those lessons and make sure we're in the best possible place. Some of the risks are described a little bit in the paper, but we'll continue to work closely with local partners on that basis. And then third question was around capital. So again, really difficult issue in lots of ways because, you know, as you'll all know, capital is different to revenue. It's big, chunky things, equipment, bits of buildings, etc. They take a bit of time and planning to put into place. Again, certainly we'd all like to be in a better position where we're not heading towards the end of the year and we do have an underspend, where we can try and find other routes to doing it. I think the medium-term planning round gives us longer-term allocations, probably for the first time in a number of years. It gives us a better opportunity to plan longer term rather than, again, an annual planning cycle that perhaps you don't get the information through until February, March, and it puts you in a difficult place. What I would say, and I don't take any pride in saying this as a finance professional, you know, we often have an underspend at this time in the year. There is often a flurry of asks and activities that take place in and around November, December time to look for other opportunities and other ways of doing that. There is also the symptom of we often get lots of new capital pots of money around this time of year as well, which causes us some technical and operational challenges to manage. So I'm not overly concerned. Clearly it would be better to have these things spent as of now, or, you know, be closer to plan, but it's not unusual equally. So hopefully that's answered all 3 questions. Thank you.
Thank you, Mark. I think the capital plan is a really important one, but we've been focused, I suspect, very heavily this year. Next year, I would like us to make sure that we fully use our capital allocation in a way that thinks strategically about how best it's used. Okay, any other questions? No, then we're going to move on to urgent and emergency care plan. Craig.
Thank you, Chair. So hopefully you've all had the opportunity to read the report. I'm just going to bring out some highlights and give a more up-to-date position, as this was obviously a point in time. It is fair to say we've had an extremely busy period since Christmas, particularly in January. Just want to mark our formal thanks to all of our provider colleagues, our voluntary sector colleagues and council colleagues who supported us in the system when absolutely needed it, as it has been a very hectic period. I also just want to acknowledge that during that period, although mental health has had a bit of a challenging week, during that period mental health fared extremely well, which was helpful because the acutes were very under a lot of pressure. Mental health actually was in a very good position, so I think that's testament to the work Chris and the team are doing to support flow and discharge. So supporting with our A&E departments was hugely helpful. It was very unusual. In a 24-hour period, we had 4 of our acute trusts in what we call Opal 4, which is our highest level, and we've never had that before, and we've also never had one of our acutes in Opal 4, and it is very rare actually our other acutes do enter Opal 4, so it was a very unique set of circumstances. So what was driving that? There was a significant number of more admissions, particularly related to walk-ins, that tells you and gives you some intelligence. We've seen flu on the increase in a number of our hospitals, novavirus as well, and respiratory infections. We also had a period of industrial action for our resident doctors prior to Christmas, so we know that also has an impact. However, when you look at the performance, whilst it has deteriorated slightly in 3 of the areas, it has only been marginal considering that pressure. So we have a 10% target for over 12-hour rates. We only deteriorated by 0.3% in December. Category 2 responses were still under the 30 minutes, although slightly longer, a couple of minutes longer than November. And our ambulance turnaround was still in the high 80s, early 90s of 45 minutes, which again, for some areas is quite a challenge. And meeting our 4-hour performance target, we did actually improve in December compared to November, but we're still slightly under the 78%. We do expect that, and I report that every January anyway about our performance dips, so that wasn't something unusual. But considering the amount of pressure we were under, you might have expected a greater deterioration. And again, I think all credit to the teams who are working extremely hard. We've heard about all the effort we've put in to our RTT, our elective care reform. Actually, I think it's equal to say that there was a shared heavy lifting load in urgent and emergency care. And that also goes for primary care. So we were working with our primary care colleagues because we did wonder whether or not some of the increased referrals and admissions were based on healthcare professional referrals. Actually, whilst there was some small hot spots in particular geographies, the majority of primary care was seeing more patients, managing more and keeping them out of the hospital. So it just goes to show the heat in the system over that period. Blackpool Hospital also had a level 2 critical incident, which is related to urgent and emergency care pressures. So that's an incident that we manage in the ICB. I'm pleased to say that we managed to stand that incident down after 72 hours. And again, I think that's all credit to Maggie and Janet and the team in Blackpool who worked tirelessly to do that despite it being challenging. The report also does pick up on some of the questions we've had previously about hospital at home, so I'm not going to go into the detail. Hopefully that does answer some of the board questions on utilisation, on the step up. If you look, it's really encouraging to see that 75% of the target that we're doing, which is around 76% against 80% national target, 75% is coming from our community stepping up. So it does go to show we've probably got another 25% capacity, and if we can work with our acutes to utilise that capacity, I think it will help both ends with step up and step down. And when you look at the through point of people, we are in the higher performing quartile to see throughput. Again, really encouraging and further work to be done. I will say, though, that, again, there is variation, so West Lancashire doesn't do as well, and I think it links to something Aaron was saying earlier about the attention we need to give to certain parts needs to be rightly disproportionate for us to see those improvements. So it is stabilising. As I said, mental health has had a challenging week, but again, the fact that we're not seeing significant number of out-of-area placements, etc., is a good measure of the success. And we are obviously monitoring our handover 45, our 12-hour waits in A&E, and our 4-hour target in A&E, as well as all the other soft intelligence measures across the community and primary care, which are equally as important. It would be remiss of me not to say and encourage people to get their vaccinations as well, because we need to make sure that all of our staff and patients are as vaccinated. So a push for that. If Sackley was here, he'd be saying the same as well. So really important that we promote that. And the messaging that we've sent out via Neil's team, which has been very helpful, is of course, if people are in an accident or emergency or in a life-threatening position, we should be using our A&E department, but we do have significant number of alternatives and they should be explored first. Thank you.
Thank you, Craig. Any questions for Craig? You look like you might have one, Silas. No? Yes.
Yeah, no, thank you, Chair. Just to add a bit further context, Craig's right in the pressures that we've seen and how we've responded as a system. I think the fact that the performance hasn't deteriorated as greatly as we anticipated is doubly impressive, given some of the changes we've had to make around capacity and probably having less flexibility this year in terms of standing up extra capacity because of some of the financial constraints that we've faced. I think we've still got future pressures ahead of us, and we're anticipating probably a second wave of flu hitting us late January, early February. So I think we can't quite say we're out of the woods just yet. So we're monitoring that situation very carefully. I think the other bit is really back to some of the earlier conversations that we were having about alternatives to GPs, alternatives to A&E. And I think some of the work that Neil and his team are doing about just sort of making sure that the public are aware about what else is out there, particularly like pharmacy support, etc. I think it's really important to note and get behind as an ICB as well. Thank you.
Debbie.
Thanks, Chair. I just wanted to try and triangulate this report back to the performance report, because when I sort of read through it, Craig, there's so much assurance, isn't there, in terms of performance and process and the impact that's being made. But the figure that stood out for me in the performance report was the fact that the system had 3,000 more people in A&E in November compared to the number that we'd had sort of last year. And I'm just wondering if we understand why, or if we're doing work to understand why, and what the learning is of that in terms of sort of commissioning or a system response to it. Because obviously when we put responses in place, we'll be forecasting based on assumed numbers. And it's just really interesting that we've had even more than we would expect, given everything that we're doing to try and put in place capacity in primary care, in community services, that it's reached a peak. So I'm curious really about the implications and understanding.
Yeah, it is a key line of inquiry, and I can't give you the learning yet, Debbie, as we are still working through what does that actually mean. So as I've said, we have seen a significant number of both admissions and attendances. It differs in different parts of the patch on each of those, but also primary care has seen that pressure. We've seen increased walk-ins, we've seen increased number of ambulances. Despite the number of ambulances, see and treat or call before convey have also gone up. We've also seen the number of ambulances attending. So there is a general increase in people using our urgent and emergency services across the board. Now, we could, and that's despite all of the additional work we've put in. I wonder where it would have been if we hadn't have put all of that additional support in. I think it would have been significantly worse. But you're right, we are working. It's hard to do in the moment when you're managing the pressures, but we've got to take some time just to step back and reflect, working with Asin's team to understand the numbers. And then some of that requires us to go out and seek some more intelligence rather than just number crunching. So the qualitative data is just important. So as you know, when I do a sort of all year round review in April, I try and bring that through in the reports to say, this is what the intelligence tells us, and this is how it's going to help shape our urgent and emergency care plans, because it's not winter plans, for next year. So I can hopefully bring some of that in more detail in the April board report.
Thank you. Julie.
Thank you, Chair. Craig, it was just about the point 7, about the single point of access, and how important this is to us in primary care, and how it really keeps the system running. Because if I spend 45 minutes on hold trying to get a patient to see a consultant, they're going to end up in A&E, which is the worst possible place for them. And much as primary care can do a lot, sometimes you need an answer the same day, sometimes you need a test. And the way that our acute colleagues are working with same-day emergency care is fabulous. And so having a single point of access that is consistent and across the whole system is so important to keep us all going. Thank you.
Thank you. The Shrewd system, that sounds rather good. I mean, that's a new system, and does that triangulate social care as well? So it's care needs across the system, is it?
Yes. So it's got huge capabilities, and we are just working through that. So I'd love to say it's able to show us all of the nursing home vacancies across the patch immediately. And probably if we had a data source to feed that, we would be able to. It's got the capability. So at the minute, it is mainly around community and acute services, and obviously it feeds in information from our ambulance services. But the work that our strategic coordination centre does the alignment with our local authorities, and we are looking to ensure that we've got that in one place at the touch of a button, rather than some of the manual elements of requiring email updates for then us to actually populate the Shrewd system. It is relatively new for us, but it is going extremely well. And I should have said I've extended the hours of our strategic command centre staff to manage handovers with our acute trusts, and to give more up-to-date position for our on-call managers because of the Shrewd system, and that's something that has been received very well. It might be more helpful at a future board, some more detail on Shrewd and the capabilities, because I think I wouldn't be doing it justice with, now without some of that more detailed and the implementation.
No, I just think it's these things. These platforms are, this is what will transform the way we are able to do things. Sheena.
Yes, just to say thank you very much for the report, and clearly what the report beautifully demonstrates is that this is a multi-system approach to how do we meet demand more effectively, and how do we work on the whole bit about reducing demand and moving upstream and making sure it ends up in the right place for people end up in the right place for their needs. What I just wanted to focus on was the 12-hour waits, and we all know that everybody would accept that is not what the standard of care we would want to offer to people, and clearly the solution to that resides in the whole system approach, and making sure that we can meet demand more effectively, and also the effective care of people within the hospital and moving people through the system. I just wanted to bring people's attention to the work that trusts have been asked to do around looking at the standards of care of acutely unwell patients, the first 72 hours in hospital. And you'll note there that there's a self-assessment that trusts are being asked to do, just to assure members of the board that we will look at that within the quality committee, and just consider, obviously we're not going to mark what trust homework are doing, but it's really what they're doing, but we were really about seeking the assurance about the focus on that, and then the learning and taking that forward, both from particularly from a system-wide point of view. So just to pull that through for members of the board. Thank you.
Great, thank you very much.
Was there, Jane, anything you wanted to add to that? No, thank you.
Thank you, Sheena. Thank you, Craig. Okay, I'm going to move on now to the governance section. Audit Committee Escalation and Assurance Report from Steve.
Yep, thank you, Chair. So as the Chair said at the beginning of this meeting, I am new in the role as Audit Committee Chair. The last meeting from which this report comes was chaired by my predecessor, and the report was written by my predecessor. So I haven't sought to change that, but I've got a couple of comments to make in mitigation to the two alerts that you've got in front of you. The first alert refers to the new ICB financial system, and this is not a finance committee, but this is relevant to us because of the effect that a new financial system can have on the auditors with whom we have close liaison. I note that neither Mark nor Steve in their updates referred to the new financial system, so the implication is that it's going a little bit better than...
It's too depressing.
Too depressing, okay. That wasn't what I was expecting you to say, or hoping you would say anyway. I have spoken to both, I've had introductory meetings with both sets of auditors in the last couple of weeks. The external auditors in particular, to whom this is relevant, are fairly relaxed about the fact that there's a new system. It adds some complexity to their work because if they do a systems-based approach and if there are two systems, they have to review two systems during the year. But they were the partner was relatively relaxed, and this happens quite often in his line of work, and he doesn't think it's going to cause any significant issues to the audit. So hopefully some mitigation to that alert. Then, excuse me, the all-age continuing care turnaround plan. All-age continuing care is clearly a big risk to us. It is considered closely by the board in these sessions. We heard from Deb earlier that it's BAF risk 7. It's got a significant amount of governance around it. We've heard from Sheena in the Quality and Outcomes report, the work that they've done, and we were alerted to some of the issues relating to the quality side of it. We've also heard from Steve in the Finance Committee report, the work that they've done about it, and some alerts there. I'm not sure, had I drafted this report, that I would have had this as an alert from the Audit Committee. I think the other committees are dealing with it sufficiently. Our role in the Audit Committee is to ensure that there is proper governance over our risks, and I think as I've just outlined, the governance is there. Specifically, in this alert, we're talking about the turnaround plan and the fact that it may have to be developed further during the year. But this was in early December. But in the Finance and Contracting Committee that met just a couple of weeks ago, and I'm a member of that as well, we've had an assurance in the report from Steve saying that the turnaround arrangements continue to demonstrate grip and control over AACC payments. So I'm relatively assured that in the month or so that has passed since this report was drafted, that the turnaround plan has been looked at in more detail, and that we are satisfied that it's going in the right direction. So alerts, yes, but mitigated by the passage of time and by events since then. The other matters in the report are for noting, and unless anybody has any specific questions, I will stop.
Thank you. Thank you, Steve. Mark, you wanted to come in on the finance system, I think.
Thanks, Chair. Yeah, I suppose just to update the board, ISFE 2 probably was an oversight on my part. It does continue to play a significant part in our day-to-day transactional processing. We're not the only ones across the country, and again we've rehearsed previously some of the challenges with that. I can just give you one example of why it causes so many problems and why it hampers us in terms of our reporting. So there's lots of instances where we have to in effect take the information out of the ledger, do something with it in a manual way and then put it back in, and that kind of doesn't help us when we're up against deadlines. So it's quite often we have to report our position by working day 7 within each month, and it's often only working day 6 or 7 that we've managed to get the information into the system to get it back out again. There's lots more cost centres, there's lots more steps in processes that we have to follow. So it's not been great. I think it's fair to say, but the team are doing a great job in trying to work through that, and I think across the country actually colleagues are working with each other to try and look at workarounds as to how to do things. I think it is incrementally getting better month on month as teams and systems get more used to each other, but it's going to take a little bit more time to work through. And just a comment on the audit position. So again, like Dave, I've had a conversation with our external auditors. I think they are comfortable the fact that we do have a split year to some degree. However, I do expect that when the national sort of service auditor auditor reports come into being, I think they'll take a bit more of a judgment on how much they can rely on that nationally or what they need to do locally. I am certainly expecting a conversation about, invert commas, increased testing costs perhaps that they're going to need. They're going to look at a cut over obviously between the old system and the new system. There's going to be a compare and contrast between the way we were doing it in month 1 to 6 compared to month 7 to 12. So it's going to be an interesting sort of audit period, I think, just in terms of how they deal with that. But they're going to be heavily reliant, as all audit teams are across the country, on the sort of the national sort of reliance that they can place on the service audit reports and what they're doing nationally and what do they need to do locally. So yeah, plenty of interesting conversations, I'm sure, during April and May. Thank you, Chair.
Thanks very much. Yeah, Steve.
Sorry, just a little bit of colour to that. We did discuss this at the Finance Committee. To a certain extent, it was out of our control, given that this was a national system that was superimposed upon the organisations. In my experience, it's a house-how of not to implement a system, as in you just throw it at someone and get on with it. So what it is in terms of the reporting is Mark and his colleagues are reporting. What it is doing is slowing stuff down. As you know, I had to defer the December meeting to January because information was not available. The practical implications of what we're dealing with is an outcome which is less effective, less efficient, and adds more risk in. However, that just falls on the heads of the people doing the work. So at a time when it's already busy, already challenging, we now, through the actions of the centre, have added more challenges to those people. And I'm not making a decision about why that was the case or why wasn't that the case. That is just the reality. So we allow Mark and his colleagues to have a little bit of his moan at the start of the committee, and then we crack on making sure we deal with the detail.
That's right. Okay, thank you very much. I'm going to move on to the Specialist Joint Committee Escalation Report. Craig?
Yes, very short report, an advise and assure. Just advising the board that we have endorsed a direct award for the OCA and ACA services in the provider selection regime, so that's a part of the committee's responsibility, and just to assure that we are triangulating the financial planning for specialist services as a part of our medium-term plan, and our contract teams are working together to consider the impact of that for future contract variations or amendments.
Thank you. Any questions? No, excellent. Conflict of interest, Deb.
Thank you. So this report presents the annual review of the conflicts of interest registers, including gifts and hospitality and commercial sponsorship, and the activity that's been undertaken over the period, and to provide assurance to the board that we're meeting our statutory requirements and in line with our ICB policy. So the ICB maintains registers of interest for all staff. In addition, we have to publish registers for those staff that are deemed as decision makers within the ICB. And the definition of those is under 7.1 within the report. We also publish registers of gifts, hospitality and commercial sponsorship that's been received or declined for all staff. And a link to the published registers is provided within the report. Relevant registers are a standing item on all board and committee or decision-making fora and agendas. And I think our policy and governance arrangements, and similar to the discussion with the BAF, ensure that we've got that transparency and any conflicts of interest. There are opportunities to declare, you know, should they arise, and we've got clear guidance as to how we would manage those conflicts as they, you know, and how they might be managed. So there is that real visibility and a good understanding throughout the organisation. We have a dedicated page on our intranet for staff, and through the corporate team we provide advice and guidance as needed. The RCB's Audit Committee has received biannual assurance of our arrangements. The last report was in September. And then following the introduction of the provider selection regime, the RCB has now developed a contracting and procurement policy, which outlines again robust procurement procedures, but particularly, you know, with an emphasis on managing conflicts of interest within procurements. And that policy has been through the RCB Audit committee as well as part of that assurance report in September 2025. In terms of compliance, for those staff that sit within the registers that we need to publish, we have 150 staff. 129 of those have updated their declarations in line with the policy. So that's 86%. And we'll continue to support those remaining staff to review and update their declarations. Conflict of interest training, it's not mandated for ICBs. However, NHS England have made available 3 online training modules, and we have adopted all 3 as part of our mandatory training requirements. So module 1 is for all staff, and again the report shows uptake there. And just to recognise as well, I think, you know, the environment that we're currently in, and we've talked about the transition and VR, and we've actually held that compliance level since September. You know, it's similar to what it was in September last year. And then the other 2 modules, the second one is more detailed and more specific to those decision makers. That wasn't rolled out until August 2025. So we're still building, you know, that sort of uptake of that training, but we will bring to the next report that full annual compliance. And then module 3 is very specific for ICB chairs. And again, we've agreed to adopt that for both our chair and our deputy chair to undertake.
Great. Thank you very much. Any questions? We are being asked to approve the annual review and publication of the Register of Interest, which I'm assuming we're going to do. Good, excellent. Use of the ICB seal, that is fairly straightforward, isn't it?
It is, thank you. So we're required to keep a register of every sealing and report the use of the seal to the board on at least a biannual basis. So this report sets out, over this reporting period, the seal has been used on 6 occasions under our scheme of delegation and reservation, and it includes the documents that seal has been used on.
Thank you. Any questions? No? Okay. And finally, report concerning matters considered in private board meetings.
Thank you, Chair. So this is now a standing report. The board has met 3 times in private since the last meeting or the last report. And I think just looking at on those 3 occasions, again, you know, we can see that there's that theme of medium-term plan and some of the requirements that we've had to do around a draft submission for NHS England, and the board being engaged and assured of that through a series of board assurance statements and discussions around model RCB blueprint and VR progression.
Thank you.
Thank you.
Questions? No? Okay, so we reach the part where we have any other business. Does anybody have any other business? No. So if I thank you all for your patience and contributions. If I could offer the opportunity to those in attendance in the public to have 10 minutes with the board for questions, and then if I could also just prevail upon board members to remain behind after that, just for